इधर का आवाज आ रहा? बस शेयरिंग भी आ रहा है? ठीक।
ये
बताएगा इसमें भाई कितने यूजर हुए
रजिस्ट्रेशन
आईडी बता देगा ना।
ये किसका है लैपटॉप?
हेलो हेलो मेरा। हाय गुड मॉर्निंग।
बैठ जा भाई।
सिग्नेचर भेज तो दिए थे नहीं आया कल।
लॉग कौन सी आईडी से लॉग कौन सी आईडी पे है? जी
डॉक्टर सीमा राय के ही तो।
अग्रवाल वाली पे।
हाँ जी अग्रवाल।
हाँ भेजे कल, मैं दोबारा भेज देती हूँ, अभी के अभी भेज देती हूँ।
आई वो तो पता ही होगा।
ठीक है।
पासवर्ड
लोगो भी भेजा था, सिग्नेचर दोबारा भेज दिया मैंने। आपके आईडी पे भेजना है आयुषी, आपके आईडी पे भेज दिया। और वी हाउ विल वी गेट टू नो? अच्छा चलो ठीक है कोई नहीं। नहीं हो गया, वो तो कल जानना था कि कितने रजिस्ट्रेशन हुए हैं। ठीक है।
कौन से वाले वेबिनार के पूछ रहे हैं?
ओके आज के रजिस्ट्रेशन कितने हुए हैं आज के?
हाँ। ये तो मैं भी देख रही थी, ये तो वो है पैनलिस्ट। फिर 1000 लोग तो बैठ सकते हैं
लास्ट में
ये नहीं 325 है। ये इन्हें इंपोर्ट करने का होता है, ये मैं देख रही थी कहाँ है। ये तो हमें एक्सपोर्ट करने का, ये मैं लेना चाहूँ।
अच्छा हो गया यार इन्होंने
इसमें
फुल कर दो।
अभी तो 11 बजे शुरू होगा,
मैं कल
पर ये तब तक जब तक ज्वाइन करेंगे बच्चे देखते रहेंगे ना। फुल कहाँ से करना है? हाँ
अच्छा डुप्लीकेशन हटा दो।
नहीं हमारा माइक ऑन है या सर की
माइक ऑन है
माइक ऑन होने के बाद से ही अदरवाइज नहीं जाता, तो अभी माइक बंद रखो। अब देखो आयुषी आ रही है क्या?
In addition to fat and
सर की आ रही है और हमारी भी आ रही
बढ़ा
है.
दीजिए ना लैपटॉप।
which are very common in us. And these are 5 viruses.
सब ठीक है
Hepatitis
तो लॉग आउट कर दूं
A,
हाँ कोई दिक्कत नहीं है
B,
इससे।
ये तो अलग है
D, and E.
थैंक यू
जा
ना
रही है उनके पास।
दोनों की आ रही है, हमारी भी आ रही है, सर की भी आ रही है. शेयर विद ऑडियो करके कोई ऑप्शन
E
नहीं है.
occurs
HDMI लगाने पड़ेंगे, वो लगाना पड़ेगा उनके लैपटॉप में HDMI।
ठीक है, देखते हैं, करती
इस
हूँ.
लैपटॉप से करोगे तो हो जाएगा HDMI लगा।
अच्छा, HDMI इससे लगा दूं और फिर म्यूट
वीडियो
कर
इसमें
दूं.
प्ले करना पड़ेगा।
ठीक है,
A and E
तो
are
HDMI
waterborne. Liver is a very vital organ of the body. You all know that liver is on the right side in the abdomen, and it is the heaviest, the largest organ, and it functions to make you happy, healthy, and smile. All what you eat is metabolized. If in excess is stored, if it is less, it is dispensed to all organs of. But sometimes, either by chance or by intent, we insult our liver. Insult can be like overfat, excessive amount of alcohol use. They can create liver to become bad. In addition to fat and alcohol, the common other causes are viruses, which are very common in Asia. And these are 5 viruses: hepatitis A, B, C, D, and E. A occurs in childhood, can occur in adults also, but generally in children. E occurs most often during epidemics or due to the sewage, the water getting contaminated, and you drink or eat that contaminated food or water. So A and E are waterborne or foodborne. Hepatitis B and C and D are all by blood and blood transfusion and can go from one man to the other, one woman to the other, from mother to the baby. Hepatitis B and D generally go together. So we will only talk about hepatitis B and C. These two viruses, B and C, have a very large infected population in the world. In fact, close to about 2.5 billion people may have past exposure to hepatitis B, and 250 million actually may be actively infected with hepatitis B. And hepatitis C, about 170 million can be infected with hepatitis C in the world. India itself has close to 45 million infected with B and about 10 to 12 million with hepatitis C. Imagine almost 5 to 6% population of India has B or C viruses, and we and you know little about it and are afraid about it. Whenever somebody says he has hepatitis B or C, they are very scared. The family thinks these guys have done something wrong. Hepatitis B doesn't come like this. They equate it with HIV. That HIV comes through sexual transmission. So B and C also must have come like that. So this guy must have been doing something funny. But this is not true. Of course, they can be transmitted sexually, but B generally comes from mother to the baby. I want to assure you that mothers generally do not do by intention. You can't choose your mother. So you are born in a family where mother is positive, and mother gets it from her mother. This is the way generally hepatitis B comes. So suppose you are 25 or 30 and you accidentally find out that you have hepatitis B. Don't blame yourself that why? Well, you got born into this family. Can you choose your mother if you have diabetes? No. Or your father when you have diabetes? No. So similarly accept it that this has come from mother. And if you are positive, that doesn't mean you have a disease because the virus remains silent for decades. Only in 10% of the people the disease occurs, and 1% die due to this. What is the disease? Let us try and understand. If the virus is there in the liver, gradually it will kill the liver cells in a proportion 10%. In 90%, nothing will happen. It stays like that. In 10%, once it is active, it causes hepatitis, it can cause cirrhosis, it can cause cancer. And all these are treatable by giving a drug called nucleoside analog. You give a drug, virus is suppressed. Sometimes you can even clear the virus. But the problem is the society doesn't accept. The person is not taken for a job, the families are broken, marriages are broken, engagements are broken. This is not fair because the guy has not done or the girl has not.
Good morning, ma'am. Ma'am, could we do a sound check quickly? It's very nice to see you.
Okay.
Could we do a sound check? Yeah, okay, we can hear you. And yes, can you say something?
Hello to everyone.
Okay, yeah, that's great. We'll start sharp at 11 a.m., ma'am.
Okay, dear.
11 a.m. and there'll be a pre-webinar survey. So there'll be the link would be posted.
Okay, it's okay, Namrata.
All right.
Okay.
Good morning, Gaurav.
So, ma'am, there is a slight change, little help. Could you switch on your video, please, ma'am? Good morning. Ma'am, the banner in your background, it is, I think that's a mirror image. So वो reverse हो गया है. We'll have to flip it 180 degrees. The way we see it, it's flipped. तो कैसे हम उसको कर सकते हैं?
Ma'am, while selecting your background, there's an option. You just click on it, mirror image to stop. It will stop, ma'am.
Now it's okay?
No, ma'am, it's the same. Ayushi, could you please help what needs to be clicked and where the option can come from?
I'll just help.
Okay, thank you so much, Ayushi.
Now is it okay? Dr. Ayushi, is it okay?
Hello. Yes, madam.
Yes, ma'am, it worked. Thank you so much.
Okay?
It's
Okay, dear. Okay, bye.
positive, don't be scared. We have to find out whether you have the virus or you have virus plus disease. If you have only the virus, then relax. If you have virus plus disease, go to a specialist and the specialist will treat you properly. Now, let's see how do you protect. If you have the virus, the rest of the family has to be screened. Those who are infected, which is likely, one out of the other 4 or 5 members can also get the virus from other. Then you get the infected guys to be treated. Once you treat, you're okay. But those who are not positive should get vaccinated. And that's how slowly we can get the virus out. So if the virus is silent, the society must understand it is not the mistake of the person. The society has to accept these people and give them the courage so that they can speak. Sometimes, let's say there is a thief, he will always think that the police will catch and put me behind the bars. So the thief runs away. So similar people who are infected with B are generally so scared they never speak. My request, my suggestion, my advice is speak, talk to the people, don't be scared. Then get tested and get treated and get rid of it. Once you are treated with the virus, it can remain suppressed rest of your life. And the doctors can easily see that you don't get a disease. And suppose the disease has occurred. Suppose there is even cirrhosis. You can get treatment. If it is advanced, you can even get a transplant and remain well. So those people, 1% who are very advanced can also get treated. Every newborn has to be vaccinated. So please remember that you will treat all those who are infected, all those who are to be born or are not infected, vaccinated. And within a period of 30-40 years, this virus can go away. Believe me, hepatitis B is not something to make people stigmatized, marginalized, and punish. It is not their mistake. Therefore, accept them. All those infected, talk about it, get out. That's what empathy campaign is. That's what we want to do, and we want to be there for you socially, psychologically, and of course, as clinicians. Now remains the other virus, the hepatitis C. This virus also is transmitted by blood, by needles generally. Suppose I am infected with hepatitis C and get a shot. The needle which comes out will have little blood. That tiny amount of blood can transmit the virus to the other person. So whenever you take blood or get a needle used, please see that the needle is sterilized. It has not been used before and the blood has been tested and negative for hepatitis C and also B. If you take such blood, no worries. But there are still large number of people, as I said, about 8 to 10 million in India. How did they get the virus and how do they know that they have the virus? My message is anybody who has got the blood transfusion or surgery before 2001, when the viruses were not tested by blood banks, please get tested. Go back and say, whenever you go to a hospital or you take somebody to a hospital, get a test for B and C, and let's say, oh, I'm free. The vaccine is only for B, mind you, not for C. And if you get your blood test with SGPT or ALT, one blood test, very cheap, you know there is no inflammation, and get an ultrasound done to say my liver is healthy. So 4 things: ultrasound, an SGPT, hepatitis B, and hepatitis C testing. If you have got it done, you are by and large quite okay. For hepatitis C, drugs are very simple, very cheap. In fact, there is a program by the country, by the government to test all and treat all. It's a 12-week treatment. You get rid of the virus. Once you are rid of the virus, 98% success with the drugs, you are happy. So please talk about hepatitis C. If you have the infection, somebody else has the infection, get treated. But those who get treated with B and C, I have a request, personal request. Talk about it. Tell 10 people, if not 100, about the virus. Ask them to shed off their fears and see that everybody can get to the doctor, can get to the specialist, can get the drugs. Both B and C drugs can make the virus suppress or clear. So henceforth, let's promise We will find out everybody, the millions who are infected, the villagers, the people in the city, the professionals, all of you have a duty to find out if somebody has hepatitis B or C. They got some surgery, their parents have B and C, anybody has a liver disease, they have got dialysis, or they have been using razors, or they have used tattoos where needles are used. All of you make sure you get yourself tested for B and C. There is another myth that the vaccine for B can only be given to newborns. I suggest anybody who has not taken a vaccine should take a vaccine for B at any age, at any time in life, just 3 shots. Today, 1 month later, and 6 months later, and you're protected for life. With these, I would like each of you to join us in the campaign of eliminating hepatitis B and C from India and make a healthy liver and a healthy country. Thank you all. दो किडनीज होती है, एक ही हार्ट होता है। सवाल ये उठता है कि इन सब में सबसे ज़्यादा ज़रूरी ऑर्गन कौन सा है? हर व्यक्ति अपने हिसाब से सोचता है। कई लोग कहते हैं दिल ज़्यादा ज़रूरी है, कई कहते हैं किडनी, कई कहते हैं ब्रेन, कई लिवर। सारे ऑर्गन्स ज़रूरी हैं, और मेरे को लगता है चूँकि मैं लिवर पे काम करता हूँ और लिवर इंस्टीट्यूट में मरीज़ों की देखभाल करता हूँ, पढ़ाता हूँ, तो मुझे लगता है लिवर ज़्यादा ज़रूरी है। और अगर लिवर ठीक रहे तो बाकी ऑर्गन्स भी ठीक रह सकते हैं, जैसे पैंक्रियास, हार्ट, सारे ऑर्गन्स को लिवर संभालता है। मेटाबॉलिक फैक्ट्री और बहुत काम करता है, 24 घंटे काम में लगा रहता है। जो आप खाते हैं उसको प्रोसेस करता है, स्टोर करता है, डिस्ट्रीब्यूट करता है, उसको हजम करने में मदद करता है, आपकी इम्यूनिटी को ठीक करता है। पर लिवर कई बार धीरे धीरे करके खराब भी हो जाता है, एज से नहीं होता। कई बार उसमें स्वेलिंग आ जाती है जिसे हम इन्फ्लेमेशन कहते हैं, सोजिश। वो सोजिश कई कारणों से हो सकती है। इसमें कॉमन कारण है, सबसे ज़्यादा कॉमन फैट है, एक्सेस फैट आ जाए लिवर में, या अल्कोहल है, और कई तरह के वायरसेस हैं, हेपेटाइटिस बी और हेपेटाइटिस सी। और भी वायरसेस हैं जो पानी से आ जाते हैं, पर जो ही वायरस का नाम लेते हैं तो ही हम लोगों को डर लगने लग जाता है कि पता नहीं ये वायरस क्या करेगा, क्या करता है, कहाँ से आया, मुझे ही क्यों हुआ। और ऐसे भारत में करीब 6 करोड़ लोग हैं और विश्व में बहुत ज़्यादा है। हेपेटाइटिस बी वाले करीब करीब 250 मिलियन और हेपेटाइटिस सी वाले भी करीब 150 मिलियन। मतलब करीब विश्व में इस समय जिन लोगों को हेपेटाइटिस बी है उनकी संख्या बहुत ज़्यादा है। जो इन्फेक्टेड हैं और जिनमें डिजीज हो सकती है वो तो और भी ज़्यादा है। तो लोग सोचते हैं, किसी को पता लगा कि मुझे हेपेटाइटिस बी है तो कहते हैं मेरे पास कहाँ से वायरस आ गया, क्यों आ गया, मुझे ही क्यों हो। तो मैं आज चाहता हूँ कि थोड़ी सी जानकारी आप लोगों को दूँ जिससे आपका भय निकल जाए, जिससे आप लोगों को लगे कि आप गलत नहीं हो, समाज आपको गलत नहीं समझे, और आप अपनी बीमारी, अपने इन्फेक्शन को समझ के और तैयार हो जाएं। हेपेटाइटिस बी जैसे अल्फ़ाबेट है ना, ये 5 उंगलियां हैं। अगर अपन सोचेंगे लिवर में कौन कौन से वायरसेस आ सकते हैं, तो एक हेपेटाइटिस ए, बी, सी, डी और ई, 5 वायरस लिवर में जा सकते हैं। ए वायरस और ई वायरस ये दोनों, अंगूठा और छोटी उंगली, ये तो भोजन पानी के द्वारा जाते हैं। लेट अस से हेपेटाइटिस ए बच्चों में होता है और एक बार हो गया तो दोबारा नहीं होता। भारत में करीब करीब हर बच्चे को, मुझे भी हुआ था, हर एक को हेपेटाइटिस ए हो सकता है। हो जाए तो फिर लाइफ लॉन्ग बचा रहता है। हेपेटाइटिस ई पानी से, भोजन से, बारिश के मौसम में ज़्यादा जब सीवेज का पानी, खराब पानी पीने के पानी से मिल जाए, या आपने ऐसे फल वल खा लिए हों जिनके अंदर की वायरस आ जाए, तो हेपेटाइटिस ई आता है। अब रहता है सवाल दो इंपॉर्टेंट वायरसेस का, बी और सी। डी और बी हमेशा साथ होते हैं, डी अकेला कभी नहीं आता, बी के साथ ही आता। तो दो ही मेन वायरस रहे, हेपेटाइटिस बी और सी। और जैसा मैंने बताया दोनों साइलेंट है, मतलब पता ही नहीं लगता, चुपचाप रहते। पर अगर हम समझ जाएं तो हम पता लगा लेंगे कि चोर कहाँ छुपा है। पहले देखें वायरस होता क्या है और कैसे आता है। शरीर में बहुत सारे कीटाणु आ जाते हैं, वायरसेस आ जाते हैं, बैक्टीरिया आ जाते हैं, तो हमको हर एक से तो कोई नुकसान नहीं होता। हेपेटाइटिस बी एक वायरस है जो कि ब्लड में जाता है और मैन टू मैन ही ट्रांसफर हो सकता है। जैसे मेरे में अगर हेपेटाइटिस बी है तो मेरे से ही दूसरे को जा सकता है। दूसरे में इन्फेक्शन है, वो अगर अपना ब्लड देगा तो तीसरे को जा सकता है। तो सबसे कॉमन तरीका वायरस के ट्रांसमिशन का, हेपेटाइटिस बी का, माँ से बच्चे को। तो जैसे अगर कोई 25 साल का व्यक्ति आया है, तो नौकरी के लिए जा रहा है, सडनली पता लगा ब्लड टेस्ट में, अरे मेरे तो हेपेटाइटिस बी है, उसकी तो जान निकल जाती है। वो सोचता है मेरे साथ ऐसा क्यों हो गया, मैंने क्या गलती की। उसके पास पड़ोस वाले सोचते हैं इसने कोई जरूर गड़बड़ किया होगा तभी इसको हेपेटाइटिस बी आया। क्योंकि बहुत समय से हेपेटाइटिस बी को HIV के साथ जोड़ दिया जाता है कि हाँ HIV है, वो सेक्सुअली ट्रांसमिट होता है, तो हेपेटाइटिस बी। हाँ, हेपेटाइटिस बी भी सेक्सुअली ट्रांसमिट होता है पर बहुत कम। जनरली माँ से बच्चे को आता है। तो जब बच्चा पैदा हुआ पता ही नहीं लगता, क्योंकि माँ से जो चीज मिली वो अच्छी लगती है, नाक कान गला सब ठीक है। तो वायरस बी को भी बॉडी अपना समझ लेती है और 25 साल, 30 साल, 50 साल तक वायरस साइलेंट रहता है, पता ही नहीं लगता। और फिर किसी किसी में लगभग 10% में वायरस से बीमारी हो सकती है। 1% ऑफ द टोटल कैन डाई ऑफ हेपेटाइटिस बी। तो मैं ये आपको बताना चाहता हूँ कि बाकी 90% या बाकी के 99% वो बेचारे डर से ही मर जाते हैं। पर हमें पता कैसे लगे कि हमें हेपेटाइटिस बी है और ये करता क्या है। वायरस लिवर के अंदर जाता है, धीरे धीरे मल्टीप्लाई करता है और मल्टीप्लाई करके लिवर के सेल्स को डैमेज कर सकता है। हर एक में नहीं, 10%। और डैमेज करके लिवर सूख जाता है, हम उसे कहते हैं हेपेटाइटिस, और फिर कहते हैं सिरोसिस। किसी किसी में कैंसर भी हो जाता है। पर ये सारी चीजें हम बचा सकते हैं, सारी चीजों को हम ठीक कर सकते हैं अगर हम देखें जिसके परिवार में किसी को हेपेटाइटिस बी है वो सारे परिवार वाले अपना टेस्ट कराएं और जो पॉजिटिव है वो ट्रीट हो जाए, और जो नहीं है, जिनमें इन्फेक्शन नहीं है, उनको वैक्सीन लगवा दें। तो हेपेटाइटिस बी के लिए ये बहुत आसान है पता लगाना कि वायरस अगर माँ से आया, उसको उसकी माँ से आया, आपकी गलती नहीं। जैसे माँ, आप कोई 25 साल वाला है, उसकी मदर है लेटर से 45 साल, उसको उसकी मदर से आया पर 45 साल तक उसको पता ही नहीं लगा लेडी को। तो अब हम क्या करते हैं, इस पूरे प्रोसेस को हेपेटाइटिस बी के 3 भागों में डिवाइड करते हैं। पहले कि वो वायरस कितना है, दूसरा वायरस से सोजिश कितनी है, और तीसरा वायरस से लिवर कितना सूखा। अगर लिवर सूखा है या सोजिश है तो दवाई देंगे, और अगर नहीं है, खाली वायरस वायरस है, बीमारी नहीं, तो कोई चिंता ही नहीं। जैसे घर में चोर आ जाए, चोरी नहीं करे, बैठा हुआ है बैठा रहे, तो हमें कोई परेशानी नहीं। तो 90% लोगों में वायरस क्वाइट रहता है, 10% में जिंदगी में कभी वायरस एक्टिव हो जाता है। पर इसकी समस्याएं बहुत है, शादियां टूट जाती हैं, सगाई टूट जाती है, नौकरी नहीं मिलती। अगर हेपेटाइटिस बी पॉजिटिव है उसको वो लेते ही नहीं। तो हमारा ये जो सोसाइटी है उससे आदमी इतना डर जाता है कि वो बोलता ही नहीं। जैसे चोर हो गया ना, उसको पकड़ के अंदर डालेंगे ही डालेंगे, तो इसी तरह अगर हेपेटाइटिस बी वाला है तो उसको नौकरी नहीं देंगे, उसकी शादी नहीं करने देंगे, बच्चे नहीं करने देंगे, उसके हस्बैंड उसको छोड़ देंगे या नौकरी से निकाल दिया जाएगा या कहेगा नौकरी बदलनी पड़ेगी, आप इस तरह की डॉक्टरी नहीं कर सकते, आप सर्जरी नहीं कर सकते। ये सारी चीजें डराती हैं व्यक्ति को बोलने से, डराती हैं उसको बाहर निकल के अपने आप के इन्फेक्शन के बारे में बताने। मैं चाहता हूं कि आप सबको बताऊं कि हेपेटाइटिस बी आसानी से ठीक हो सकती है। अगर पता लगा कि खाली वायरस है, बीमारी नहीं है, तब तो कोई चिंता ही नहीं, वायरस को किसी भी दिन दवाई से दबा सकते हैं। और अगर बीमारी है तो उसका इलाज होगा तो वायरस धीरे धीरे कम हुआ, बीमारी भी ठीक हो सकती है। बाई द वे कोई कैंसर हो गया, बाई द वे कोई सिरोसिस हो गया, लिवर खराब हो गया तो बदल देते हैं, लिवर बदल जाता है, ट्रांसप्लांट हो जाता है। तो हमें ये मान के चलना है कि भारत में जो 4.5 करोड़ लोग हैं जिनमें इन्फेक्शन है, वो सब एक दूसरे से बात करें, पता लगाएं कि इसका इलाज है। और भारत सरकार ने तो अब एक प्रोग्राम शुरू कर दिया है जिसके अंदर सबका फ्री डायग्नोसिस, सबका फ्री ट्रीटमेंट हो सकता है। और आप अपने आप को दूसरे से बात करें, डरे नहीं, छुपाएं नहीं कि मुझे है। हम लोग जो ये मुहिम है, जो मिशन है, जिसके लिए कि भारत में किसी को भी अब हेपेटाइटिस बी वाले को परेशानी नहीं। और हाँ, सबसे ज़रूरी बात, अगर कोई बच्चा आज पैदा होता है उसको तो आप 100% बचा सकते हैं। जिसकी माँ को वायरस नहीं है उसको भी टीका लगाना है, जिसकी माँ के वायरस था और बच्चा नया पैदा हो रहा है उसको भी टीका लगाना है, और इम्यूनोग्लोबुलिन भी देना है। अगर आपने उसको वायरस का टीका लगाया, हेपेटाइटिस बी का, और इम्यूनोग्लोबुलिन दिया तो बच्चा सुरक्षित, एबॉर्शन की कोई ज़रूरत नहीं, टर्मिनेशन ऑफ प्रेगनेंसी की कोई ज़रूरत नहीं, हस्बैंड को वाइफ को नहीं छूना, उसके साथ नॉर्मल मैरिटल रिलेशन नहीं रखना, ये सब गलत। आप नॉर्मली रह सकते हैं, वाइफ से हस्बैंड को बहुत रेयरली ट्रांसमिशन होता है, तो इसलिए ये संभावना कम है। तो हम अपने आप को लेट अस टॉक, लेट अस गेट टेस्टेड, लेट अस गेट ट्रीटेड, और इस तरह से हम अगर करें तो 4.5 करोड़ लोगों को जिन्हें बी है वो धीरे धीरे सोर्स ही खत्म हो जाएगी, और हर नया पैदा होने वाला बच्चा उसको हमने टीका लगा दिया। तो अगर हम ऐसा करें तो 20-25 हो सकता है 50 साल में सारे हेपेटाइटिस बी वाले खत्म, भारत हेपेटाइटिस बी से मुक्त हो जाएगा। अब रहा हेपेटाइटिस सी, जो दूसरा वायरस, मैंने 2 बताए थे ना, एक बी और एक सी। सी वायरस भी वैसा ही, ये ब्लड से आता है, जैसे इंजेक्शन की वही नीडल बार बार लगाई जाए, जैसे मेरे में हेपेटाइटिस सी हो और मेरे को इंजेक्शन दे तो उसके नीडल में भी थोड़ा ब्लड आ जाता है, वो ब्लड में हेपेटाइटिस सी होगा, उसी नीडल से दूसरे को लग गई उसको भी हेपेटाइटिस सी हो सकता है। तो हेपेटाइटिस सी जनरली नीडल से, ब्लड से, ट्रांसफ्यूजन से एक से दूसरे को जाता है, और सोर्स इसका भी मैन टू मैन ही है, मतलब एनिमल से वायरस आ जाए ऐसा नहीं। तो अगर हमने, जो भारत के अंदर करीब 8 लाख के करीब लोग हैं जिनको हेपेटाइटिस सी है, उन सारे लोगों को, सॉरी 8 मिलियन के करीब भारत के अंदर हैं, 80 लाख के करीब, उन सारों को अगर हम लोग इलाज कर दें, और इलाज बड़ा आसान है, 3 महीने की दवाई दीजिए, सस्ती दवाइयाँ हैं, और वो भी दवाइयाँ फ्री मिलती हैं सरकार से। अगर हमने वो दवाई दे दी और 3 महीने में 95 से 98%, और इतना अच्छा इलाज और है ही नहीं, किसी तरह की एंटीबायोटिक में भी इतना अच्छा इलाज नहीं कि भाई 98% लोग ठीक हो जाएं सिर्फ 3 महीने की दवाई से। तो हम अगर ये सारे लोगों को ट्रीट कर दें तो हेपेटाइटिस सी भारत से खत्म हो जाएगा। और ट्रीट कैसे करें वो व्यक्ति बताता ही नहीं, तो इसका भी बहुत आसान तरीका है। कभी किसी को
A beautiful morning and a warm welcome to all our delegates. It's so heartwarming to see my professors, ex-professors and the teachers who have helped me become what I am today. So A very wonderful morning to Dr. Seema Rai, Principal Dr. B.R. Dr. Satya Jain, Dr. Samina, and I could also see Dr. Meeta for a brief moment. Ma'am, if you could please switch on your video, and Dr. Rachna Narang. I welcome the host for the day for the occasion of the National Webinar on Recent Advances in Prevention and Control of Hepatitis B and C, jointly organized by Dr. B.R. Medical College, Hospital and Research Center and the Institute of Liver and Biliary Sciences under the Empathy campaign. Before I hand over the platform to Dr. Archana, to formally begin the webinar, may I please request our participants to kindly take a brief survey. The link that has been displayed on the screen right now, kindly click on that link. It is also posted on your chat boxes. If you could kindly go to the chat box, click on the link. It will take you to a short questionnaire, about 5 to 10 questionnaires. It must not take more than 3 minutes of your time. Alternatively, you can also scan the QR code that is being displayed on your screen right now and kindly take a little while to answer the question and answers. And then we'll shortly begin formally. Video.
Dr. Namrita, Dr. Neeta will be moderating the whole session.
All right, thank you, ma'am. All our participants are requested to kindly follow the link that has been posted in the chat box. And if there's any assistance, you may please post your queries in the chat box itself. Thank you all for submitting your responses. The link shall remain open for a few more minutes, and so you may kindly take your time. It's required that you kindly take this survey pre-webinar, and there'll be one at the end of the webinar also. So the participants are requested once again to kindly take both the surveys to be able to generate a link that enables them to download the e-certificates. Once you've submitted both the surveys, you'll be able to have in your emails the e-certificate link, and that would be enabled. So please do take the time to follow these links, which will be posted in your chat box, and they'll be remaining open for the duration of the webinar. And now may I kindly please hand over the platform to Dr. Meeta to formally begin the webinar with a very, very warm welcome to the host of the day. On behalf of the ILBS family and the Empathy Campaign, I welcome Dr. Meeta from Dr. B.R. Sur Medical College to kindly begin the webinar.
Thank you, Dr. Namrata. On behalf of ILBS and Dr. B.R. Sur Homeopathic Medical College, I welcome you all for this webinar. This webinar is very important in respect that all medical personnel, whether doctors, nurses, or paramedical staff, need to upgrade their knowledge regarding hepatitis B and C. And why this is important? Because there are certain conditions which carry stigma and discrimination with them. And to address these issues, the most important thing is awareness and measures which can reduce the discrimination. Though awareness is more important for the public, but equally important for all medical and paramedical nursing staff, so that they can upgrade their knowledge with respect to newer developments in the management of disease and prevention of these diseases and the current guidelines which are available, how to tackle these diseases. For this, the two institutions have jointly organized this webinar. The main focus is on the reorientation on the subject and how to reduce the stigma and discrimination through awareness. For today's webinar, we have our esteemed panelists. We have Dr. Sareen, Dr. S.K. Sareen with us, who is Vice Chancellor ILBS. He is Professor Hepatology and Director Institute of Liver and Biliary Sciences, New Delhi. He was instrumental in setting up the institute under the auspices of Government of Delhi. He is also the Director, WHO Collaborative Center on Chronic Liver Diseases and Viral Hepatitis at ILBS. He serves as adjunct faculty at molecular medicine at JNU due to his deep interest and contributions to translational science. He has more than 650 publications to his credit, and he is also recipient of various recognitions and awards, both national and international. Next panelist is our Dr. Umesh Kapil. He is Professor and HOD of Epidemiology, ILBS New Delhi. He is MD in Community Medicine from AIIMS Delhi. He is an academician and educationist par excellence, and he has more than 4 decades of experience in research and teaching. He has led numerous funded research and demonstration projects and published more than 340 publications. And he is also a member of National Task Force of ICMR, BIRAC and DBT. He is also recipient of various awards, including the National Awards for 1992-96. And he is among the identified amongst 2% of global scientists for research contribution in the field of child health by Stanford University, USA. The next panelist is Dr. Archana Ramalingam, who is scientist E at ICMR NIH Chennai. She is also MD in Community Medicine from JIPMER, Puducherry. She is recipient of Professor R.K. Kerr Best Postgraduate Gold Medal in Community Medicine in 2014. She has worked in multiple research projects at JIPMER, Puducherry and MEMC, Delhi and at ILBS. She has been a resource person for several workshops on research methodology and basic epidemiology. She is recipient of Ford Foundation Epidemiology Grant and has been awarded Best Oral Papers in several conferences, including IPHE and Jericon. She has also published several articles in the national and international journals of repute. Her areas of interest include non-communicable diseases, including non-alcoholic fatty liver disease and metabolic syndrome, viral hepatitis, community-based interventions, health promotion, and medical education. So I welcome all panelists from ILBS. We have panelists from Dr. B.R. Sur Homeopathic Medical College. We have with us Dr. Seema Rai, who is principal of Dr. B.R. Sur Homeopathic Medical College and Hospital. She has a vast experience of more than 3 decades in teaching, clinical care, and administration. Moreover, she has also published various articles in journals. She has also led research projects in renal stone, gallstones, female diseases, and thyroid diseases, along with Dr. Archana Narang. Our next panelist is Dr. Samina. She is professor in Dr. B.R. Sur Homeopathic Medical College. She has more than 3 decades of experience in teaching and clinical care, and she has taught more than one subject, including our homeopathic philosophy, anatomy, and parasitology. Next, we have amongst us Dr. Satya Jain, who is HOD Community Medicine, and she has also a number of experience in various subjects, including homeopathic subjects along with community medicine. She has also gained the experience of more than 3 decades in Homeopathic Medical College by teaching and in clinical care. She is also looking after pediatrics OPD in Dr. B.R. Sur Homeopathic Medical College. I welcome all the panelists for today's webinar. Now I will hand over the mic to Dr. Archana Narang, who is Associate Professor in Department of Surgery. She is also looking after Department of Medicine and Department of Gynae and Obs. She is also looking after thyroid clinic, and she has done a number of studies on subclinical thyroiditis and hypothyroidism. I welcome you, Dr. Archana Narang, and I hand over the mic to you for your keynote address. Before Dr. Archana Narang, I will request Dr. Seema Rai for her welcome address and objectives of this webinar.
Good morning, everyone. It is a moment of extreme pleasure that I got the opportunity to welcome you all. I congratulate Institute of Liver and Biliary Sciences on embarking on the mission to address global problem of viral hepatitis, which continues to claim over 1 million of lives each year. And it becomes all in the more baffling to realize that the death caused due to viral hepatitis are higher than the tuberculosis, HIV, and the malaria if we put all together. I thank the team of the Empathy who is spearheading the campaign to empower people against hepatitis, and the ILBS under the vision of much revered Dr. Shiv Kumar Sareen for leading a team we are proud to associate with today. I welcome all the esteemed speakers for the day who are taking us through the webinar on recent advances in prevention and control of hepatitis B as well as C, which is jointly organized by, as Dr. Namrata said, jointly organized by Dr. B.R. Sur Homeopathic Medical College, Hospital, Research Center, and Empathy Campaign, an initiative of ILBS and Airport Authority of India. In consonance with the National Viral Hepatitis Control Program, the aim of this webinar today is 1, to provide the platform and a conducive environment to the participant to engage in healthy dialogue and share knowledge in respect of hepatitis B and C, and to generate the awareness on hepatitis B and C amongst the participant, and also to raise awareness for the available preventive strategies such as the immunization schedule and immunization, especially of hepatitis B at the birth dose or high risk group and to the health worker, and also understanding hepatitis B and C challenges which we are facing today, and also use safe practices, safe drinking water, hygiene, and the sanitary toilets. This webinar on recent advances in prevention and control of hepatitis B and C thereby gives impetus to increased involvement of healthcare professionals. I do hope certainly that the webinar would provide meaningful insight regarding the global issues of hepatitis B and C. With the stellar speakers for the day, all our participants are able to utilize the opportunity to understand and advance their knowledge of viral hepatitis and can contribute to the battle against HBV and HCV for achieving the goal for which today we have all gathered here, of making India free from hepatitis B as well as hepatitis C. Once again, I welcome you all. Thank you.
Now I request Dr. Archana Naran for her keynote address.
Good morning to all the honorable speakers, panelists, and all the participants. We are well aware that hepatitis is a silent epidemic. And in India, viral hepatitis is a major health challenge that requires an urgent response. In our country, we have estimated 40 million chronic HPV infected people, constituting approximately 11% of the estimated global burden. In the Indian scenario, viral hepatitis has intermediate to high endemicity with chronic HPV infected people. Population prevalence of chronic HPV infection in India is around 3 to 4% and 1% for HCV. However, there are pockets where prevalence of hepatitis C has been observed to be relatively high, particularly in the Northeast. Dealing with the challenge, we feel privileged to gain a new momentum to our ongoing fight against hepatitis B. Institute of Liver and Biliary Sciences has been monumental in the field of liver health and research, and the initiative today offers a platform where two different schools of medicine today have come together, and their influences helps us understand how best an effective patient care, community health plan, and knowledge dissemination can bring about an impactful change in the society. Further, it may help clear certain common perceptions of the alternative medicine, especially about the homeopathy, which have been associated with miracle cures, safe medicine, and long-term treatments, etc. As a homeopath myself and an ambassador of the college, I would like to share that miracles are only a domain of Almighty. But we as practitioners only approach the disease as a condition with the same understanding of the human body as other schools of medicine, but with a varied approach to the disease. We treat the man in disease, the whole and the holistic approach, and not the disease in man. Furthering this concept, if I may add, there are no specializations in homeopathy, but focusing on today's topic of viral hepatitis, as well as we all understand, the liver carries out several necessary functions. We all know that liver is very important because it detoxifies the harmful substances from our body. It cleanses our blood and make vital nutrients. Hepatitis B virus and C are the major causes of acute and chronic liver diseases like cirrhosis of liver and hepatocellular carcinoma. Cirrhosis occurs in response to damage to our liver, which may also be caused due to viral infections as one of the causes. Each time our liver is injured, it tries to repair itself. In the process, the scar tissue forms. And as the disease progresses, as the cirrhosis progresses, more and more scar tissue is formed, making it more difficult for the liver to function. And once the liver is damaged, it cannot be undone. So if the liver affections, they are diagnosed early, then it can be treated. But if it is damaged, then it can rarely be reversed. In homeopathy, we have many medicines which are given in different liver disorders. And if I talk about hepatitis B and C, homeopathic treatment can be given in conjunction with as an adjuvant therapy with the conventional treatment. In advanced liver diseases, along with the homeopathy, we also need hospital management and close monitoring. We do need important procedures like draining of the abdominal fluid, stopping of the blood loss, increasing the blood protein levels, and so on. And definitely, it needs to be performed under the expert guidance. With the homeopathic treatment, we have treated many cases and we have tried to limit the liver damage. We have tried to treat the liver conditions also, viral infections and jaundice also, with the help of various medicines which are available to us. Homeopathy helps to control the cellular damage. Though it cannot cure and reverse the scar tissues, and at the same time, it is not possible to change the pathology which has occurred in the liver. But definitely, if it is diagnosed at an early stage, homeopathy helps a lot. Because if it is introduced at the early stage of liver infections only, then the homeopathic medicines can effectively help to manage the patient's symptoms and limits the damage which is caused to the liver. Homeopathic medicines can prevent the progression of liver damage, and in very early cases of liver cirrhosis also, the medicines can restore the majority of the normal functions of the liver. I would also like to share here that as far as the diagnostics of the liver diseases are concerned, particularly when I'm talking about hepatitis, we at the college are also performing several tests, including the qualitative test for hepatitis A, B, and C. We have also collaborated with Deen Dayal Upadhyay Hospital to vaccinate our staff for hepatitis B. And our housekeeping staff is screened for hepatitis by Biomedical Waste Management Committee and Kayakalp Committee regularly and annually. Because understandably, this section of the staff is particularly vulnerable to contract the bloodborne infections, especially hepatitis B. I look forward to welcoming the speakers of the day. Today's webinar, we will be listening to Dr. Mania Prasad from ILBS. She will be talking about burden of HPV and HCV in India. We have Dr. Ayushi Rastogi from ILBS with us. She will be talking about transmission and prevention of HPV and HCV at the community level. We have Dr. Archana Ramalingam from NIE Chennai. She will be talking about screening, vaccination strategy, and health education for HBV and HCV at community level. Dr. Ekta Gupta, who will be telling us about the National Viral Hepatitis Control Program. And then we have Dr. Rahul Gehlot with us from ILBS, who will help us in administrating the I-Pledge. I do believe that today's webinar will provide deeper insights into our understanding of viral hepatitis B and C, and will benefit our students and all the faculty members and staff of Dr. B.R. Soor Homeopathic Medical College Hospital and Research Center in understanding the challenges of viral hepatitis. Thank you so much. I hand over the mic to Dr. Meeta Gupta.
Thank you, Dr. Archana. Now we will start our sessions. First session is on burden of HPV and HCV in India by Dr. Mania Prasad. Dr. Mania Prasad is Assistant Professor, Clinical Research and Epidemiology at ILBS New Delhi. She has 35 international and national articles in Medline Index journals. Her area of interest is epidemiology, medical research, systematic reviews, and meta-analysis and evidence-based medicine. She has facilitated many workshops on research methodology, evidence-based medicine, and grade 2. She is a gold medalist in MD final exam and a recipient of International Epidemiology Association Fellowship. Over to you, Dr. Mania, for your session.
Thank you so much, Dr. Meeta, and I extend heartfelt gratitude to Dr. B.R. Soor Medical College for collaborating with ILBS on this very important webinar. I'm sure that this endeavor will go a long way in strengthening the government's efforts for elimination of viral hepatitis. I also thank our esteemed panelists, Dr. Ajit Singh Badoria, sir from AIIMS Rishikesh, who we are so grateful to for lending his expertise on a very important session today and for the Q&A session as well. I also thank my good friend Dr. Archana from NI Chennai, and of course Dr. Ekta, our professor here in microbiology at ILBS. So without much ado, I think I'll begin talking about what I've been assigned to talk about, and that's the burden of hepatitis B and C in India. What this will contain is a brief background on why it's important to talk about this. I will present some reported estimates from across India and summary estimates from reported literature on the prevalence of chronic infection of HPV and SCV in India. I'll do a brief critical review of this literature and provide estimates from recent studies. I'll also emphasize the rate of complications and will finish with some steps needed. So needless to say, liver is a very important organ in the body, situated right here in the right upper quadrant. And as Dr. Narang alluded to, it serves a whole range of functions. It's a metabolic factory. It works 24/7 to serve the body in detoxifying, regulating hormones, maintaining blood sugar levels, produces important proteins and blood clotting factors. And so it's a very important organ. What damages the liver? Primarily, there are three things and some uncommon causes as well, but mainly three things: alcohol, fat, and viruses. So alcohol, as you all know, is the most commonly talked about in terms of liver damage. Fat in the liver. So fatty liver disease is due to become one of the most common causes of liver-related morbidity and mortality, and it's purported to overtake other causes in the near future. And finally, viruses. So this is what we're going to talk about today. There are 5 viruses which I will tell you about. But what is hepatitis? It's basically inflammation of the liver parenchyma. So the term arises from hepa and itis, meaning liver and inflammation. So when the liver is affected by hepatitis, it reduces the liver function. The types of hepatitis are 5, A, B, C, D, and E. B, C, and D are the types of hepatitis that are blood-borne in transmission. So Dr. Ajit will talk more about this in the next session. And A and E are transmitted through contaminated food and water. So basically 5 types, and what we're talking about today is the blood transmission type. So hepatitis B and hepatitis C. When we talk about the burden of hepatitis B and C, what we must remember is that we're not just talking about the acute infection itself. So very often there's just an acute illness, which is characterized by fever and jaundice and malaise, and the person recovers in a few days or a few weeks. But very often what happens with HBV and HCV is that the hepatitis persists. So the infection persists within the liver for a long time. And this is what is chronic hepatitis. And when there is inflammation in the liver due to these viruses for a very, very long time, then it results in two very important complications. And these are irreversible damage to the liver, which is cirrhosis and hepatocellular carcinoma, so cancer. Now, with cirrhosis, what happens is that when there's chronic inflammation, the healthy liver tissue gets replaced by scar tissue. So there's fibrosis, and with progressive fibrosis, there's quite a lot of liver damage due to this scarring, which is cirrhosis. And then over time, cirrhosis progresses to liver cancer. So that's hepatocellular carcinoma. So both hepatitis B and C are very important causes of both cirrhosis and hepatocellular carcinoma. And I will tell you more details in subsequent slides about the magnitude of the rate of these complications. Why do we need to worry about this? Because hepatitis is a leading cause, one of the leading causes of mortality worldwide, and certainly a very important public health problem in Southeast Asia. It's a communicable disease where mortality is observed to be increasing, and it is responsible for at least as many, if not more, deaths annually than TB, AIDS, or malaria. So around 90% of these are due to hepatitis B and C infections. What is very important to consider here is that these infections are easily preventable. They are amenable to easy prevention and control. We have very effective vaccine for hepatitis A and hepatitis B, and it's not very expensive. Moreover, we have treatment. So there's actually a cure for hepatitis C now, and we have effective drugs for managing hepatitis B. And so we must focus on this. This is particularly pertinent in the time of the pandemic. COVID-19 poses a major challenge in achieving hepatitis elimination, because so many of those interventions that are so important to break the chain of transmission have suffered due to the pandemic. And it's been reported that hepatitis has suffered the most and has suffered the highest disruption. And that's even more than that for HIV, malaria, and tuberculosis. So important interventions like vaccination and screening and health education, it's been interrupted very severely. And it's time that we turn our focus again to this very important disease. So what are the numbers? If I talk about worldwide, 296 million people were living with chronic hepatitis B and 68 million with chronic hepatitis C. According to WHO estimates, viral hepatitis accounts for around 1.4 million deaths worldwide. And in 2019, hepatitis C resulted in an estimated 820,000 deaths, and most of these were from cirrhosis and hepatocellular carcinoma. So you can see here that it's a huge, huge problem, both in terms of morbidity, illness, as well as deaths. So mortality from primarily these two causes, that's complications, cirrhosis and hepatocellular carcinoma. It's very important to know about the burden of those liver complications, and I'll tell you why this is worrisome for India, because the trend is rather alarming. 50 to 40% with chronic HBV virus develop serious sequelae during their lifetime. And both of these infections with cirrhosis account for 720,000 of these deaths, and hepatocellular carcinoma in around 500,000 deaths. This is the WHO map for the numbers. So the way that they report this is in terms of prevalence of surface antigen. So globally, as I said, 296 million people. And then this varies across regions, of course. Western Pacific very severely affected, as well as the African region. But even in Southeast Asia, you can tell that of which India is a part, has important magnitude, a very severe magnitude due to hepatitis B. For hepatitis C as well, 58 million globally, and then again there's variation across the WHO regions. And so these are the numbers. Again, important problem. as is depicted by the 10 million people who are suffering in Southeast Asia region. In endemicity, in terms of endemicity, how does India figure? It is in the low endemicity region, which means that, well, this figure is of course again subject to the robustness of the estimation, but here in this map, it's less than 2% the prevalence of hepatitis B, and more on this in the next slide. And then there are regions across the world that have a very high endemicity. You can see here that there's Africa and there's parts of Asia that are suffering very severely. Within Southeast Asia region, again, there's a gradient. So there are some countries that have an increased prevalence of HBs antigen, and such countries such as Indonesia, Thailand, Myanmar, Bangladesh. And similarly for HCV as well, the prevalence varies across countries in the region, and with some showing more prevalence than others. So if I talk about studies that have reported the prevalence of chronic hepatitis B infection, the estimates mostly come from 3 research groups. The first is the paper by Schweitzer et al., which reported a prevalence of 1.46%. And this number in the bracket is the confidence interval. So that's like the margin of error, the whole range of plausible values consistent with the data. And how this compares to the worldwide estimate is what you can see here. There's also the WHO estimate, which is not very different. And you can see that there's also an overlap in the confidence intervals between both the estimates. And then there's the CDA Polaris estimate, which is slightly higher than others, but then again, a significant overlap in the confidence intervals. So those are the 3 main sources that tell us the prevalence of chronic hepatitis B currently. Just a word on what these research bodies are and what they've reported. They've all reviewed peer-reviewed literature, so that's how the estimate has arisen from these 3 research groups. And they've all systematically summarized the data from previous literature that has reported prevalence in India and other countries as well. What they differ in is the number of countries and the countries themselves that they've included in summarizing the literature for obtaining the estimate, and also some characteristics of the population. So some exclusions varied across these research groups. Some included high-risk population, some did not. And that could possibly explain the discrepancy in the estimates from these 3 research groups. So this is purported to be a reliable one, the first Schweitzer et al. Paper, and what they summarized was 129 studies, including 3.7 million subjects. The prevalence reported was 1.46%, with an estimated 17 million chronic carriers. If you look at the trend across the decades, you'll see that there has been a reduction. So from 1950s to 1980s, 2.62%, to 1990 to 2013, if you make a subgroup of the studies, then the pooled estimate is 1.44%. And so this is the estimate from WHO, as I alluded to earlier, 1.95%. And in under 5 years, what they reported was 0.16%. They also compared it to the pre-vaccination era, and you can tell that, of course, there's been a sharp decline, possibly attributable to vaccination. And then this is the slightly higher estimate from the CDA Polaris Observatory Group. If you look at some recent studies, what you will see is that there's high variation in the type of population that they've included in all of these prevalence studies, which is possibly responsible for the discrepancy in the prevalence estimate that they've reported. There's also difference in the testing method, with some using surface antigen and some RNA. And so you can see that there are some people who tested in HIV patients and some that did community-based studies, And then there are some that tested all the patients in a hospital. There were also a number of studies that were done in blood donors. And so that's again one concern with regard to methodology, because very often the people who turn up for blood donation are healthy people, and we're concerned that this might be an underestimate then. With regard to prevalence of chronic hepatitis C, the estimate is around 0.09 to 15%, and 6 to 12 million chronic HCV patients are there. 3 million to 9 million persons with active HCV infection. And what chronic HCV infection accounts for is 12 to 32% of HCC and 12 to 20% of cirrhosis in India. So there are some limitations. The quality of reporting is variable across studies. There's a combination of robust and non-representative studies in different age groups. There's also a paucity of data on specific groups, and therefore affecting the representativeness of the samples. And mostly the samples are subnational with very few nationally representative studies. So this is the reported mortality from hepatitis B, and you can tell here that most of the mortality, by the shading, you can see that the lightly shaded part is hepatocellular carcinoma for both HPV and HCV, and the darkly shaded one is cirrhosis. And you can tell that in terms of the number of deaths, the highest proportion is due to these two things. And then even in terms of the absolute numbers, this is the 8th standardized death rate per 100,000. And there's certainly a lot to be concerned about here, because a lot of deaths are attributable to these two complications. What is worrying is that if you see the incidence of liver complications due to HPV, that's the left side of this table. While the global trend is showing a reduction when you compare 2007 to 2017, so the percentage change is minus 2.55. In India, there's actually an increasing trend. So the incidence is actually showing a positive percentage change. That's 7.54% change from 2007 to 2017. And if you look at the deaths, the 8th standardized death rate for liver complications, again, this is both cirrhosis and hepatocellular carcinoma. Again, while the global estimate showed a reduction in the percentage change, for India, we had a 2.15% increase. And of course, this has the important caveat in interpretation that these estimates rely on certification of cause of death, which is very poor in India. But still, I mean, it's something that should signal action for a public health approach. And if you look at just liver cancer again, the point estimate, at least, not the confidence interval, the point estimate signals a positive or an increase in death rate. And also for cirrhosis as well. So negative percentage change globally and positive for India. This is what has prompted the WHO to implement the global health sector strategy. And other speakers will talk more about this. But what is aimed at is a 55% reduction in deaths from chronic HBV and HCV by 2030, and a 90% reduction in new cases by 2030. So lastly, what is required is a public health approach, and that's the only way out of this crisis. We will be seeing how the program has implemented all of these different measures, or has emphasis to implement it, and certainly we need help from all sectors and all lines in the medical discipline so that this problem can be tackled adequately. Thank you, and I'll hand over back to Dr. Meeta to take the proceedings forward. Thank you very much for your attention.
Thank you, Dr. Mania, for your informative lecture. And we are really better informed about the details of the burden of the HPV and HCV in India. Thank you so much. Now I will welcome Dr. Ajit Singh Bhadoria. He will be speaking on transmission and prevention of hepatitis B and hepatitis C at community level. Dr. Ajit Singh Bhadoria is Associate Professor in Community and Family Medicine at AIMS Rishikesh. He is MD in Community Medicine and has 5 years of experience at ILBS as an epidemiologist and project coordinator to WHO Collaborating Center on Viral Hepatitis. He has more than 150 publications and the recipient of prestigious ICMR Professor B.C. Srivastava Award 2016. He is also Nodal Officer for National Viral Hepatitis Program. He has been a team member in WHO Global Hepatitis team and contributed in the development of guidelines for HCV self-testing and hepatitis C. And he has also contributed in developing SOPs for enhanced reporting of acute hepatitis cases as a scientific committee member for Southeastern Asian region for WHO. I welcome you, Dr. Ajit, and over to you for your session.
Thank you so much. Good morning, everyone. And thank you, Dr. Meeta, for introducing me. Whatever you have listened from her, it's like all the achievements which are mentioned by her, the credit goes to ILBS only. I worked there for 5 years and learned from Dr. Professor Shiv Kumar Sareen sir. So I'm really thankful to him for making me what I am today. And I'm very thankful to my previous mentor, Professor Umesh Kapil sir, for providing me this opportunity to contribute in this very useful webinar, which is targeting awareness, spreading awareness, disseminating knowledge, because this is something which is very much required for hepatitis B and hepatitis C, because most of the infections, they are asymptomatic. So if people, doctors like you and people, they'll be knowing about hepatitis B and hepatitis C, they'll come up for testing, and then we can at least identify them and treat them. So thank you so much, Dr. Meeta. Now I'll share my presentation. Today I'll be talking about what are the different modes of transmission for hepatitis B and hepatitis C, because this is very important to understand why this transmission, why these diseases, they are transmitted. We have a good experience from COVID-19 that we want to identify people. We are doing contact tracing, we are doing isolation just to block transmission. So for infective diseases, it's always a very good strategy if you're targeting elimination by 2030 that you identify transmission methods and then try to block them so that you can prevent new cases. Right, so with the, I'll just mention the objectives which I want to fulfill after this session. I want you all to understand what are the different modes of transmission. I want you all to know at least what are the different possible preventive approaches to block this transmission, maybe by general precautions, maybe by our understanding about HIV, because the mode of transmission for hepatitis B and hepatitis C is almost similar to HIV. And you should know about vaccination. So vaccination, I'll tell you in brief about vaccination, then it will be covered again by Dr. Archana in the subsequent session. So vaccination is very important and the key strategy for hepatitis B elimination. And then I'll brief you about post-exposure prophylaxis. If there is exposure to hepatitis B blood during your clinical healthcare service deliveries, then what should be done? So as mentioned by Dr. Mania, there are 5 viruses, A, B, C, D, E. A, first one, and last one, E. They are transmitted enterically, that is fecal-oral transmission, transmitted through contaminated food and contaminated water. Then between 1, B, C, and D, they are transmitted parenterally, that means through blood or body fluids, through unsafe blood, unsafe injections, unsafe sex. Hepatitis B, C, and D, they transmit. So this is what you should know broadly about different types of virus which causes hepatitis. So if we talk about parenteral transmission of hepatitis B, C, D broadly, it's mainly through blood and blood products. Sexual transmission, perinatal transmission. Perinatal transmission means mother to child transmission at the time of delivery, which is also known as vertical transmission. And fourth one is inapparent horizontal transmission, where sometimes there might be some exposure to blood or body fluids when among the close contacts, like children playing together or people living in close contacts. So there are some cases, some chances of that time also the hepatitis B and hepatitis C, they can be transmitted. So that is known as horizontal transmission. So vertical transmission, horizontal transmission, sexual transmission, and blood-borne. So if we talk about blood-borne transmission, you can see most common approach is through blood transfusions. When you are transfusing a blood or blood product, like fresh frozen plasma in dengue cases, when you're transmitting those products which are infected or contaminated with hepatitis B or C or other transfusion transmitted infection, you can transmit these infections. So we want that safe blood should be there, that is screened for all these TTIs, and then that safe blood should be transfused to the donor, to the recipient. And then nosocomial routes, other nosocomial routes which we know from HIV experience also, they can be transmitted through dialysis when we are doing dialysis in the patients who are suffering from chronic kidney disease. Unsafe injections, needle stick injuries, which are very common, mostly goes unreported, but that these needle stick injuries should be reported, and then post-exposure prophylaxis should be taken for hepatitis B and for HIV also. Surgery, dental procedures, even during organ transplantation. So if there is a kidney transplantation or liver transplantation from a person who is infected with hepatitis B and hepatitis C, but not knowing because he was asymptomatic, then this can be transmitted. So there are multiple ways in which we will try to prevent all these type of transmissions, but still these are the common modes of transmission. In this slide, I'm specifically talking about hepatitis B. So when we specifically talk about hepatitis B, you should know that perinatal transmission, that is mother to child transmission, is the most common one. So if there are many studies which has documented that if you go for family screening, you'll find out that among 60%, among 40%, you'll find out hepatitis B surface antigen positivity among those who are first degree relatives. That means, which gives a hint that there must be a mother to child transmission. When one person is positive, siblings, they're also positive. So perinatal transmission is the most common one for hepatitis B. Then it might get transferred through horizontal transmission and through other healthcare associated transmission, which we have already discussed. Sexual transmission is also common with hepatitis B, but lesser than HIV but higher than hepatitis C. And even by sharing syringes among people who inject drugs. So IDUs, intravenous drug users, or we also call them as PWIDs, people who inject drugs. They are also a very important high risk groups, where by sharing the needles, they transmit the disease, hepatitis B, hepatitis C, and HIV to each other. This slide is very important to understand that chronic infection, if the transmission occurs at birth, like if there is a transmission which is occurring at birth through mother and child transmission, the chances of chronic infection is very high, about 90%. So this child will develop chronic infection 90% more chances to this kid, as compared to those who get this infection in later part of their life. So early infections leading to more converting into chronicity, more converting into cirrhosis, more converting into liver cancer, and more death can occur. So if we can block this mother to child transmission for hepatitis B, we can block both. We can decrease new infection and we can decrease mortality also. And these two are the main targets for elimination of hepatitis B by 2030. So this graph is very important to understand. Earlier the infection, more chances of converting this infection with hepatitis B into chronic infection. Then prevention, if we talk about prevention, vaccination is the most important strategy. So we know both birth dose and 3 doses of hepatitis B, they are in the universal immunization program. You might have heard from Dr. Sareen also in the video which was played before this session. He was also emphasizing on this strategy that if we can give birth dose and all 3 vaccinations in the infancy, then we can prevent the transmission of hepatitis B to these kids, and maybe after a few decades we'll see a steep decline in the number of cases of hepatitis B. So timely birth dose is important, and primary 3 doses, they are also very important. Then we can also target vaccination of healthcare workers because they are exposed during their working hours. Then we can also target high risk groups where we feel like people who inject drugs, commercial sex workers, or similar high risk groups for HIV. They also should be targeted so that they can get vaccine for hepatitis B. Other than vaccination, other strategies, they are very similar to HIV: screening of blood, safe injection, taking safety of the people who are working in healthcare setting. Occupational safety is important. Harm reduction means we want to reduce harm which we know that will occur in a particular high risk group. For example, in people who inject drug, so we know they transmit infection by sharing needles. So if we can provide them sterile set of needle and syringe, then they may not involve into sharing of needles. So providing needle and syringe set to PWID is a harm reduction intervention. And safe sex is always a good strategy for not only for HIV but also for hepatitis B. But yes, vaccination is the key intervention. So in this slide, you'll be knowing that hepatitis B vaccination is very efficacious. So if you give 3 doses of hepatitis B vaccine, then the protection is around 98 to 100%. In COVID-19 vaccine, we are getting a protection of only 70 to 80%, but still we are doing mass vaccination. We are giving vaccination to all. So you can think of like how good this hepatitis B vaccine is. So that's why vaccination coverage should be increased. And this is also very important to know when you will be assured that after taking hepatitis B 3 doses of vaccine, you are now protected against hepatitis B infection. So this you can check by doing your anti-hepatitis B surface antigen titer. This antibody titer, if it is more than 10, that means you are protected. Remember always that if it comes more than 10 anytime in your life, no need to go for booster, no need to go for any other intervention, because sometimes I've seen that people, they ask like if it was more than 10 earlier, now it is less than 10, do we need a booster? No. If it was more than 10 anytime in your life, no need to go for any booster dose, no need to go for an rechecking of anti-HBs titer. Be assured that you are safe from getting hepatitis B infection in your life. This graph is also very important because it tells about the coverage. So if we think hepatitis B vaccination is an important strategy, we want that coverage should be high. So our target is to achieve 90% of the coverage. So you can see overall the coverage is below 90% for most of the regions, WHO regions, and overall for the world also it is less than 90%. That means we need to emphasize more on our universal immunization program so that those who are unreached, those who are unreachable, those who are not coming up for vaccination because of any reasons, we need to find out those reasons and we have to solve those reasons, and so that this coverage can be increased. This graph tells you about the impact of vaccine coverage on hepatitis B infection. So you can see from 1990 to 2014, when the vaccine coverage is increased from 0% to around 90%, chronic infections they have dropped significantly with these years. So that gives a clear-cut evidence in favor of vaccine that if we increase the vaccine coverage, hepatitis B transmission, new cases of hepatitis B, overall burden of hepatitis B will drop. So we talked about timely birth dose as an important strategy. So why this is important? So this is important, you can see from this graph. If you block this transmission, the chances of chronic infection drops. So that's why we want birth dose coverage should be increased. So the chances of symptomatic infections increases. That means acute infection with mild fever, jaundice, or malaise, but chances of chronicity will go down because we don't want these kids to get chronic infection later on and then convert into cirrhosis or liver cancer in their later part of life. That's why hepatitis B birth dose is very important. So what is the definition of timely birth dose? The definition of timely birth dose is that you give hepatitis B vaccine birth dose within 24 hours of birth. So this is very important. The coverage is low. We want to increase it to as much, we want to increase it to 90%. but this is very low still because of because of multiple reasons. We'll discuss that in the subsequent slide. So there is data which says if a newborn get a birth dose and then subsequently only 2 doses out of 3, at least 2 doses, then effective prevention of mother to child transmission is 90%, which is very good, right? So that's a promising strategy if we want to eliminate hepatitis B. So what is the birth dose coverage by region if we talk? So in 2016, it was very low, less than 50% for globally also, and for Southeast Asia region, where India is the part of this region. So in our case also, it is less, it is around 34%. So that is very low. So we have to increase it to 90%. We want our 100%, I'll say 100% of newborns to get birth dose at the time of birth. So why this mother to child transmission is more common in developing countries, in India, in other developing countries? So this is more common. Why? Because there is high birth rate. We have low institutional deliveries, still not 100% achieved, poor antenatal care, poor birth hygiene, then increasing the chances of transmission, poor coverage of hepatitis B birth dose. We have seen it's only 38% in globally, low hepatitis B testing during pregnancy. So with these, because of these all risk factors available in developing countries, that's why the transmission of mother to child transmission of hepatitis B is very high. So what can be done? The solution is testing during ANC, give a birth dose within 24 hours. And if the mother is HBsAg positive, also give hepatitis B immunoglobulin. This is hepatitis B antibodies, already preformed antibodies. They can also be given within 48 hours if we want to prevent mother to child transmission. So we know what need to be done. So if everything is available, we have that knowledge, I think implementation is the only challenge which we have to face. So that was mainly about hepatitis B. So for hepatitis B, most common mode of transmission is mother to child transmission. How we can stop is test pregnant female for hepatitis B. If they are hepatitis B positive, give hepatitis B immunoglobulins along with birth dose. So birth dose is mandatory irrespective of hepatitis B testing. We want that coverage should increase. Now from this slide, we'll talk about hepatitis C. So hepatitis C is mainly transmitted through unsafe blood and unsafe injections. So if we can take care of safety of blood and blood products, there should be no hepatitis B or hepatitis C or HIV or other transfusion transmitted infections in the blood. If we can provide safe blood to our blood recipients, then this hepatitis C will go down. Then unsafe injections practices should be stopped. We don't want our private practitioners or our healthcare settings that they are giving unsafe injections to the patients who are coming for some other reasons. So in terms of doing benefit, we are doing more harm by transmitting hepatitis C. So these two things, if we can take care of these two things, then hepatitis C can be at least the transmission can be blocked. Other than the unsafe injection practices in the healthcare settings. Second is sharing of needles by people who inject drugs. So we need to target harm reduction, as I have talked in hepatitis B transmission. So we have to distribute safe syringes and needles to this group so that they do not share needles and they do not transmit these infections. Other than this approach, these mode of transmission, hepatitis C is also transmitted through making tattoo practices. In our tribal areas, people, they make tattoos on the body, they go for body piercing, they go for nose piercing, ear piercing, and so if there is somebody in who's practicing body piercing and tattooing, we can educate them, we can train them so that they can use sterile approach in doing those procedures so that the transmission can be blocked. And unprotected sex, sometimes mother to child transmission, and sometimes inapparent horizontal transmission can also occur for hepatitis C. But mainly for hepatitis C is unsafe injections and unsafe blood. So how we can prevent it? We can prevent it by giving safe blood, safe injections, harm reduction interventions, safe sex, and taking care of occupational health of those who are working in healthcare settings, so that through needle stick injuries or through other mode of transmission, they should not get infected. We do not have a vaccine for hepatitis C similar to hepatitis B, but yes, we have drugs available. So one thing which I want you all to know, that now we have drugs available for hepatitis C, which can cure hepatitis C in only 3 months. So they are oral safe drugs freely available under the program. So if you see any patient of hepatitis C, just refer the patient to any treatment center in the district, they'll get free treatment. So this test and treat policy will be a good approach, a good strategy, or I'll say the best strategy if we want to eliminate hepatitis C. So for hepatitis B, vaccination. For hepatitis C, test and treat. Test, identify, and then treat. Why? Because both hepatitis B and hepatitis C, they are asymptomatic in 95% of cases. So when people they are asymptomatic, they'll not go to any healthcare setting for any care. So we'll miss them. So we have to identify the hotspots. We have to identify the high risk groups. We have to go and get them tested. These tests are also free in the program. So screening is free, diagnosis is free, and treatment is free in the program. So test and treat approach can prevent hepatitis C transmission. So nosocomial transmission means when we transmit any infection in a hospital or in a healthcare setting. So what can be done as per WHO guidance? Hand hygiene is important. Safe handling and disposal of sharp biomedical waste management. This is very important. Safe cleaning and sterile equipment use is very important. Then safe blood is important, and training of people. Like through this today's webinar also, we are training our doctors from this homeopathic college, so that you can also be aware about hepatitis B and hepatitis C, their burden, how we transmit these infections, what is available in the program. So you know everything about hepatitis B and hepatitis C, so that you feel confident enough whenever you see hepatitis B and hepatitis C patient, you feel confident enough to tackle in those cases. Then prevention of hepatitis B and hepatitis C in people who inject drug is also very important. So what we can do is, we know that for hepatitis B, we have a good, safe vaccine. So this vaccine can be given to this high risk group, so that, and we can test their antibody titers also, and we can tell them after receiving 3 doses of vaccine, you are safe. Now you'll never get hepatitis B vaccine. Hepatitis B infection. So vaccination of this group is also a very important strategy. Then we can provide incentives also, like if you complete all 3 doses of vaccine, we'll give you some incentive that can also come up as a good strategy. Providing sterile needles and syringes, as I have discussed earlier, this is harm reduction approach. Then we know that they are dependent on some drug or some substance or opioid. So if we can treat this opioid dependence, there might be some treatment available in homeopathy also. So if we can target this opioid dependence treatment, so they might get out of this habit of using intravenous drugs, and they can be out of the risk also of transmitting hepatitis B and hepatitis C. So this is also a very important strategy for this particular group. Then sexual transmission, we all know through HIV that sexual transmission, how we can prevent sexual transmission. The first and the most important is correct and consistent condom use. Then second is, we know that those who are involved in multiple sex partners, or those who are involved in sex business or sex workers, they should be tested, so that we can test them and treat them early and block that particular transmission. Elimination, discrimination, and gender violence should also be targeted. And not only medical, but social services should also be provided to this vulnerable group, so that we can make them educated about hepatitis B and hepatitis C along with HIV, that these are also 2 more most dreadful diseases, which infections which can occur to you through your unsafe sex. So that they can be aware about these 2 infections, and can go for testing and can go for vaccination. This slide is about post-exposure prophylaxis. If there is any exposure to hepatitis B, what should be done? If the person is unvaccinated, give start hepatitis B vaccine after giving 1 dose of hepatitis B immunoglobulin. If the person is previously vaccinated, go for antibody titer check. If it is more than 10, no need to do anything. Whenever the titer is once more than 10, no need to give any treatment, any booster, anything for hepatitis B. If it is less than 10 and is checked first time and was never 10 before in the life of that person, then go for again hepatitis B immunoglobulin and only one vaccine booster, because we know that there is a previous history of vaccination, complete vaccination. So this is post-exposure prophylaxis for hepatitis B. This slide is very important. This was published in 2017 in Global Hepatitis Report. I'm mentioning about global health sector strategy on viral hepatitis. So you should know that our main strategy is that impact is to see that hepatitis B incidence and hepatitis C incidence goes down. Incidence means new cases. We don't want new infections to occur. We don't want new people to come up with hepatitis B and hepatitis C infection. So if we want to see this impact, we have to target these 5 service coverages. First is 3 doses of hepatitis B, which we want to increase to 90%. So currently it is around 87%. So this is something which is achievable by 2030. We want to increase this coverage to 90%. If we want to prevent hepatitis B mother to child transmission, then current coverage of birth dose is only 34%. So we have to increase it to 90%. This is something where we need to work hard so that our birth dose coverage among newborn increases to 90%. Then safe blood, that means percentage of donation screened. So it is currently 85%. We want to increase it to 100%. That 100% of the blood should be screened properly and then only transfused. Unsafe injections, still 5.2% they are getting unsafe injections in Southeast Asia region. We want to decrease it to 0%. And harm reduction, as I have discussed earlier also, that we want to give injection sets, sterile sets of needle and syringes to people who inject drug. So currently only 29 sets they are getting per person. We want to increase it to 300 sets per person. So if we'll increase the coverage of all these 5 interventions to this level, we'll achieve 90% drop in new infection of hepatitis B and hepatitis C. So I think this is something which is a guidance for our healthcare system, that this is what we need to do to achieve the decrease in incidence by 90%, so that we can achieve elimination of hepatitis B and hepatitis C by 2030. So just to summarize it, simple messages: that hepatitis B and hepatitis C, they are parentally transmitted. Hepatitis B infection, if occurs in infancy through mother and child transmission, the chances of chronic infection, chances of chronicity increases a lot. So we want to prevent this infection as early as possible. Vaccination is the most important strategy for hepatitis B. Birth dose coverage should be increased, because there is data which mentions that birth dose with only 2 additional doses, and there is 90% efficacy in preventing mother to child transmission. Anti-HBs titer, we should know that if it is more than 10 any time in your life, that it indicates adequate protection from hepatitis B infection. Then other than all these strategies, safe blood, safe injection practices, and safe sex, they are effective in preventing both hepatitis B and hepatitis C. So this was my last slide, and I'll be happy to take any question. Over to you, Dr. Meeta.
Thank you, Dr. Ajit, for a wonderful lecture. We are really enlightened by your lecture, and we will be taking question answer session at the end after all sessions are completed. Now I will invite Dr. Archana Ramalingam. She will be speaking on screening, vaccination strategy and health education for hepatitis B and hepatitis C at community level. I would like to again introduce her. She is scientist E at ICMR NIE Chennai, and she is MD in community medicine from Puducherry, and the recipient of Professor R.K. Kar Best Postgraduate Gold Medal Award in Community Medicine in 2014. And she has worked in multiple research projects at Puducherry and MEMC, and including ILBS. We welcome you, ma'am, and over to you for your session.
Thank you, Dr. Neeta, for that kind introduction. And I also at this point would like to thank Professor Kapil and Dr. Shivkumar Sareen sir for giving me this opportunity to come and discuss with you about vaccination, health education, and screening of this very important topic close to our hearts, elimination of viral hepatitis B and C. So without speaking further, I will share my screen. And I hope my screen is visible and I'm audible.
Yes, ma'am, you can continue with it.
Thank you so much. So today I would be talking with all of you about screening for viral hepatitis B and C. Whom should we screen and what are the tests that we are going to use for screening? What are the important concepts related to vaccination for viral hepatitis B? I'm sure Dr. Ajit, who spoke before me, has covered vital aspects, and I will also touch upon certain other aspects. And briefly, I will touch upon the importance of health education for a condition as vitally important as that of viral hepatitis B and C. So firstly, coming on to screening for hepatitis, who is it that we should screen for hepatitis B and C? So as far as the national program is concerned, it gives guidance saying that anyone who walks into a testing center must be given screening services for B and C if they ask for. However, priority or preference for screening should always be given to individuals who are at high risk for getting viral hepatitis B and C. But otherwise, anyone who reaches the testing site should be offered services under the National Viral Hepatitis Control Program. So who are these individuals who are at high risk for hepatitis B and C? Now, having listened to Dr. Ajit's lecture, I'm sure you know the transmission dynamics of these two conditions and already are aware of who are the high-risk group. Pregnant women, especially for B virus, mother-to-child transmission is the most important mode of transmission in the country. It's also a risk for C virus. Individuals who are using injection drugs, and these are a specific group, very, very high risk for hepatitis C, of course for B as well. Medical professionals, doctors, you, me, and everybody who's attending this lecture, nurses, anyone who's working in the front line in healthcare systems, people who undergo repeated hemodialysis, and individuals with HIV or individuals who are at risk for getting HIV, that is individuals who have multiple sexual partners, men who have sex with men, people who use injection drugs, and of course, there are a few other groups which are also at high risk, like close household contacts of hepatitis B and C patients, people who have a habit of getting tattoos at unsterile parlors. These are also some of the other groups of individuals who are at high risk for hepatitis B and C. And these are the people where we need priority screening. Of course, anyone who walks into a clinic must be offered services as per the program. So what are the screening tests that are available for testing hepatitis B and C? Now, several rapid card tests have come up in the recent years to diagnose B and C, but always for hepatitis B, we look for hepatitis B surface antigen detection, and for C, for screening, we look for antibodies to HCV. I'm sure Dr. Ektar in her lecture coming up next will speak more about this. Just to apprise you of the rapid antigen tests, rapid card tests. The rapid card tests are single-use disposable tests. They are easy to use, do not require additional reagents, and can give you results within 15 to 30 minutes. Just a sample has to be poured into the sample collection well, and then through the lateral flow immunoassay, you will be able to easily see whether the test line is positive along with the control line, which indicates a positive test. So these tests, the rapid card tests, both for HPS-AG as well as for anti-HCV, have got reasonably high sensitivity and specificity, and therefore can be very good screening tests for B and C. The confirmatory diagnosis and who should be treated would be dealt with in the subsequent lecture. When we come to an important preventive strategy for viral hepatitis B, then the focus or the most important intervention is vaccination. So when we talk about hepatitis B vaccine, it is a vaccine which contains a viral protein, that is the hepatitis B surface antigen. Dr. Ekta later in her lecture will show you the structure of hepatitis B virus, and you can also look at the various important viral proteins there. The protein that is present in the vaccine is the hepatitis B surface antigen. And initially, when the vaccines were initially in production, we used to obtain these surface antigens from the plasma of individuals with chronic infection. However, nowadays, most of the vaccines use a recombinant protein that is obtained from gene being inserted into yeast or mammalian cells, and then these proteins are cultured. So there are several different types of hepatitis vaccines. The most common vaccine that adults take is a single antigen vaccine, especially in our country, it is usually Inject B. Whereas for the children or the infants, the government program gives you the pentavalent vaccine, which along with hepatitis B offers protection for diphtheria, tetanus, pertussis, and Haemophilus influenzae B. In the private sector, if you get your child vaccinated, the one that is usually given is a hexavalent vaccine. In addition to the 5 diseases that I already mentioned, it also offers protection against polio in the form of injectable polio vaccine. So these are the most common types of hepatitis B vaccines. Of course, in the West, you also have Twinrix, which is hepatitis A and B vaccine together. So when we look at stability and storage, hepatitis B vaccines are fairly stable and can be easily stored in ice-lined refrigerators available at most peripheral institutions like that of the PHC. However, they are very sensitive to freezing, and as a result, freezing of these vaccines should be avoided at all costs. When we come to dosage, for the infants and newborns, usually 0.5 ml of the vaccine is given. For adults, it is about 1 ml. Whereas for hemodialysis or immunocompromised individuals, usually a higher dose is required and 2 ml is given of hepatitis B vaccine. When we talk about the schedule, and this is a very important slide, all healthcare workers and individuals associated with healthcare must know the hepatitis B vaccine schedule and must advocate all expectant mothers to vaccinate their children as per the schedule, and also any adult who may be at risk of getting viral hepatitis should be definitely vaccinated against hepatitis B. So for infants and newborn, the schedule is birth dose that is given within 24 hours preferably, followed by 6, 10 and 14 weeks dose. So 3 primary doses and 1 birth dose. For adults, the schedule is 0, 1 and 6 months. Now, what about the site of administration? Usually, just like all other vaccines for newborns and infants, anterolateral aspect of the thigh is the most preferred one, even for hepatitis B vaccine. For the adults, the preferred site is the deltoid region. And usually, we do not give the vaccines in the gluteal muscles for preventing the risk of sciatic nerve injury. Now, what is the amount of protection offered by hepatitis B vaccine doses? If your child is taken just 1 dose, then 16 to 40% is the protection. Whereas if your child is taken 2 or 3 doses, the protection is more than 80%. 2 doses, 80 to 95, and 3 doses, 98 to 100%. So you can see that hepatitis B vaccination is a fairly efficacious vaccine and must be given to all children and can protect the children from getting hepatitis B virus infection. Now, once you're vaccinated, does it mean that you're immunized? Not always. So checking off anti-HBs titers, like what Dr. Ajit mentioned, could give you evidence or proof that you have actually developed antibodies and you are actually protected against hepatitis B. So what level of anti-HBs is considered to be protective titer is a level of more than 10. So any individual who's an immunocompetent individual who has at least had 1 antibody titer test done with a level of more than 10, then he can be fairly sure that he's protected for a long time against hepatitis B virus and therefore does not require any booster dose. So more than 90% of the vaccine responders remain protected for long durations, and studies suggest can be protected up to 30 years. So what happens when an adult misses the hepatitis B vaccine scheduled dose? So if the schedule is interrupted after the first dose, then usually second dose can be taken as soon as possible. However, care should be taken that the interval between the second and third dose should be at least a minimum of 8 weeks. Whereas if only the third dose is missed, then you need to administer the dose as soon as the individual remembers it. Another question that we often get asked is, what about if the vaccination history is unavailable or unreliable? Now, you may come across individuals who either have forgotten their vaccination history or do not have records, or are not sure whether they have completed their 3 doses of vaccination schedule. In such cases, there is no harm in administering extra doses of single antigen hepatitis B, because it's really not harmful. And whenever the vaccination history is unreliable, it is often advisable to give an extra dose to ensure protection. Another question that we often get asked is, can hepatitis B vaccine given in pregnancy? Now, since this is not a live vaccine, neither pregnancy nor lactation is a contraindication and can be given safely during pregnancy. And specifically, high-risk pregnant women, especially ones who have got multiple sexual partners or ones who are being considered for treatment of other sexually transmitted infections, pregnant mothers who are currently using injection drugs, and those who have a hepatitis B surface antigen positive sex partner must undergo vaccination if they have not already been vaccinated. When we look at the adverse events, most of the adverse events associated with hepatitis B vaccines are mild. Usually people can experience some amount of pain. There could be some erythema or swelling. Some individuals can experience a high rise in temperature and a headache. However, severe side effects or adverse events are quite rare. Now, the most severe adverse event that is associated with hepatitis B vaccine is a severe allergic reaction or an anaphylactic reaction. And this is seen in very rare conditions to the tune of, 1 case per 1 million vaccine doses administered. And perhaps this is the only contraindication for hepatitis B vaccination. That is, if an individual already has a severe allergic reaction or has had an anaphylactic reaction to hepatitis B, then this vaccine is contraindicated and only in that group. This vaccine is definitely not contraindicated in individuals who are premature, so you can safely give it to premature children, low birth weight children, small for gestational age children, or children born to mothers with HIV infection, or even children with neonatal jaundice. So these are not conditions where you should not give the vaccine. So hepatitis B birth dose is safe in all of these subgroups of newborns. And since there is no live virus, it is safe in individuals with immunodeficiency. And of course, there is no mutual interference when it's co-administered with any of the other childhood or adult vaccines. Now, several speakers before me have already touched upon and have told that the WHO's initiative to give a global health sector strategy for elimination of viral hepatitis talks about several key areas where interventions are needed, and also speaks about what are the targets, if achieved, can result in elimination of viral hepatitis by the year 2030. So with regards to vaccination, the key service targets are for the 3-dose primary immunization, as well as for the birth dose, which prevents mother-to-child transmission. If you look at the Southeast Asian region, the coverage for 3-dose is about more than 85%, and the coverage of birth dose is rather dismal. It's only about 34%. So the target, if we achieve in order to look at elimination of viral hepatitis by 2030, is to get 90% of all the children who are eligible for vaccination with the 3 doses, and also 90% of all newborn children must get their birth dose at a timely manner. So what is the coverage of hepatitis B vaccine in India? If you look at the data from NFHS 4, which was done in 2015-16, showed that coverage of 3 doses of either pentavalent or hepatitis B vaccination was slightly more than 60%. Whereas the recent survey, which is done in 2019 to 21, shows that the coverage has improved and it is to the tune of about 84%. So we are doing well in terms of improving the coverage, but we have not yet reached the target of 90%. So slowly we need to progress as healthcare workers, encourage and advocate for mothers to get their children vaccinated and give all the 3 doses of primary vaccination. And why is it important? Why the birth dose is specifically important? Now, Dr. Ajit has already talked about this. Just to reiterate with you, look at this very important graph. It talks to you about what happens to chronic infections and symptomatic infections based on the age at which an individual is infected. If you will see, if an individual is infected at birth, the chances of that person to develop chronic infection is quite high, to the tune of even 80 to 90%. Whereas if an individual acquires the infection at much later time in their life, like older children or adults, the chances of getting chronic infections is very, very low. As a result, the key take-home message is, in cases of viral hepatitis B, early infection has got a greater chance for getting converted into chronic infections. So mother-to-child infections need to be prevented, and birth dose is very, very important. So what is a timely birth dose? Timely birth dose of hepatitis B is nothing but administering the first dose within 24 hours, as early as possible after birth, but at least within 24 hours. And this is very good for preventing perinatal transmission. And studies have shown that giving birth dose followed by at least 2 to 3 doses effectively prevents mother-to-child transmission in about 90% of the children. So, as already stated, the birth dose coverage, WHO had advocated it from 2009, and by 2014 still, the birth dose coverage is dismal. In countries like India, the institutional delivery has increased over the years, and now we are having more than 75% institutional delivery in almost all the states, but still the coverage of birth dose even in India is to the tune of about 44 to 45%. So still a long way to go in birth dose coverage for hepatitis B. Considering that an early infection is more associated with chronicity, this is where I think concerted efforts are needed from the government and all the other stakeholders, especially the healthcare providers. Now, just to touch upon immunoglobulin, it is a good practice to give immunoglobulin along with the vaccinations for children born to mothers with hepatitis B surface antigen positivity. One of the bigger challenges with HBIG is its high cost and of course limited availability. But one thing that you should be cautioned about is when you give HBIG along with the birth dose, you must give it in different limbs using separate syringes. And that is one thing that I want to caution you about. So to summarize the important aspects of vaccination, the 3-dose vaccine schedule must be followed in all children along with the birth dose. And if an immunocompetent individual has got an antibody titer of more than 10, that indicates adequate protection and he or she does not require a booster dose. And for prevention of mother-to-child, timely administration of the birth dose is the most important aspect. And it is one of the key areas where we are really doing bad. So I think concerted efforts are needed in this. And if the birth dose is followed by 2 additional doses, then that definitely is going to prevent the mother-to-child transmission for hepatitis B virus. And before I conclude, just to touch upon health education, when we talk about health education for viral hepatitis B and C, we really need to commend our partners, ILBS, for doing and taking the initiative in a major way. They have developed a lot of posters, conducted a lot of competitions. They do have brand ambassadors who keep posting about viral hepatitis and keep increasing the awareness. They have got a very good social media presence, and they have done several campaigns in the past and have conducted several stakeholder meetings and conclaves with key important policymakers, so that viral hepatitis is really brought on the front page, and the government does take initiatives in this regard. So they have got several posters with key, SOCO messages like hepatitis C is curable, and, get tested or vaccinated for hepatitis B. Prevention of mother-to-child transmission is important. Why is it important for birth dose vaccinations to be held? They've also had several posters, which just generally, tries to bring viral hepatitis onto the front page, like this one and this one. In addition to health education and posters, I think ILBS has also done several competitions, and one very interesting competition that they held is the cartoon competition, where there were participants from over 40 countries who joined together in this initiative, and they came out with brilliant cartoons which could be used for health education. They have also worked with other stakeholders, and we know that school children and school teachers are important stakeholders. They ran an initiative called as the Happy School Initiative. I was fortunate enough to be a part of this. And, we had literally trained almost all the principals and key teachers in almost all the government schools in Delhi. And of course, the empathy campaign does have a brand ambassador who works actively in this area and gives messages on social media. And she also has done a lot of videos for awareness related to hepatitis B. And we do have a lot of technical informative videos from the faculty at ILBS. We've got videos from Dr. Shiv Sareen himself, and then we've got videos from key players like Dr. Ekta and others, which give quality information about viral hepatitis B and C for anyone who is interested. And the empathy campaign does conduct I pledge campaigns from now and then, and therefore, brings awareness to various other healthcare professionals, as well as various other health workforces and other partners, strategic partners in the awareness campaigns for viral hepatitis B and C. They do now and then bring in key policymakers. You can see several parliamentarians here who were involved in a conclave that was conducted, and therefore awareness at different levels is really being targeted. And they do have a very good social media presence on Twitter platforms, on Facebook, as well as on YouTube. So I think I must commend ILBS's efforts to increase awareness for viral hepatitis B and C. So thank you, and that's all I have for you. Over to you, Dr. Neeta.
Thank you so much, Dr. Ashna. It was indeed a very informative lecture from your side. Now I would like to invite Dr. Ekta Gupta. She will be speaking on National Viral Hepatitis Control Program. Dr. Ekta works as professor and head of clinical virology, ILBS New Delhi. She is MD in microbiology from King George Medical College, Lucknow. She has received the Best Scientist Award Gold Medal for outstanding contribution in clinical research by ICMR. She is a technical resource person for developing the National Viral Hepatitis Control Program in India. She has several extramural research grants, both at national and international level, to her credit. She is also course faculty for the WHO Collaborating Center at the ILBS. She has more than 80 scientific publications in indexed national and international journals, and she is also the author of 11 chapters in books. She has major interests including hepatitis viruses, transplant viruses, and dengue virus. Over to you, Dr. Ekta, for your session.
So, very good morning, good afternoon to all of you. Can you hear me?
Yes, ma'am, we can hear you.
Okay, so I'll share my screen. Now, can you see my slides also?
Yes, ma'am.
Okay. So, very good morning. The topic which has been given to me is National Viral Hepatitis Control Program in India. So you've heard from the previous speakers about what is the incidence prevalence of hepatitis, how it is transmitted, prevented, what are the screening. So I'll just tell you about what, in a very simplistic manner, what is happening at the Government of India level, where are we now, and what are the things about the viral hepatitis in India, where do we stand now? Now, this is again and again, we just, before starting, we just want to highlight that, yes, the problem of viral hepatitis was felt, and it was seen that it is it is rising higher than HIV, malaria, and tuberculosis. So the country needs to, so this was seen in the year 2014, 15, 16. And so not only in India we realized it, but globally, WHO, they all realized that this is another set of infection, viral hepatitis, especially by B and C, which needs to be taken care of, and each country has to do something about them. So this was again told by Mania earlier. So the globally, the global health sector strategy. So wherever you feel in globally that there are infections. There is a public health problem coming. Now, how to tackle that? They set targets, then they approach each government that now you start doing something, and then the government does some initiative. So this was how the National Viral Hepatitis Control Program came into existence. This was a problem which was globally shared through the Global Hepatitis Report, and they set the targets that you have to do something with the way the B and C cases are rising, new cases and deaths related to them. You really need to control it by 2020 and 2030. So they had set this target of 2030 that the new infections means anybody who acquires for the first time, it should reduce by 90% by 2030. And the deaths by B and C should also reduce substantially, that is 65%. These have been shared earlier, so I'm not going to tell you, but these are the global targets which were given. Means they had said that these are the problem areas. This is the baseline information in 2014, and now start working on it so that you achieve these targets by 2030. Now, what are the targets? But so globally, people collected the information, and then they found out that yes, where we are lacking. We are lacking in hepatitis B vaccination. Mostly we are lacking in prevention of mother-to-child transmission of hepatitis B, that is birth dose vaccination. Because, and especially in India, we are not doing all 100% institutional deliveries. And so at birth, the vaccination which is given within 12 hours or 24 hours is not being given. So what we have to focus is, we have to push towards institutional deliveries. You know, anybody who comes to an ANC who is pregnant should be told that you should go, no ghar deliveries, it has to be institutional. And within 12 hours, the child should receive the first dose of hepatitis B. Safe blood practices needs to be ensured. Baseline data also showed everybody is doing because of the NACO and AIDS awareness program, which is there from for so long. So so along with HIV, B and C testing is mandatory. So somehow that target is there. Injection safety, yes, because of the drug uses and the HIV, again, you can say. So the percentage of unsafe injection usage was also not much of a problem, and we have to still bring it down. Now, what was the major problematic area each country felt was in terms of diagnosis? So you can see a huge gap in B and C diagnosis at baseline, just 9%, and you have to bring it so high. Treat, and naturally, if you are not diagnosing enough, then whom are you treating? So that is the area which everybody came to understand, that what is lacking in B and C programs is that you are not doing enough of diagnosis, and that is why enough of treatment is not being given. This is again the studies which have shown, see a huge gap. So actually, if you see, the number of infected are so high, but those who are diagnosed, how many are screened? What is the conventional? We are only screening for B and C in those who come to donate blood and organ in ANC setting. Or, you know, in India, it's a very unusual practice of screening people before surgery, which is wrong, I should say. So we are not offering a lot of screening and testing for B and C. So if you're not offering a lot of, so all your preventive, all your diagnostic, all your treatment efforts are not being utilized to its highest potential. So this is the gap we all need to look at, that how to increase the uptake of diagnosis. In India, so viral hepatitis is a huge problem. There are 5 viruses, and if you can count them, it's easy to remember if you count them like 5 fingers. A and E, they are small, and so although they are hyperendemic, means they are there in our food, water. So it's not that some out, and they can occur as focal outbreak, but they are usually there. But the contribution in causing the serious disease in form of liver failure and all is less. So you can see, although this problem is hyperendemic, but they are not causing serious illness. So A and E, which are food and waterborne jaundice, are there as a problem, but the more effort needs to go to B and C, which can cause chronic infection, can lead to liver failure and other consequences of cirrhosis and death to the and severe morbidity and mortality to patient. And these are ones which are transmitted through bloodborne, and they are the ones which are usually asymptomatic. So diagnosing them and is difficult. So you need to intensify your efforts for B and C. We know these are just data that 40 million B and 12 million. It's a huge number. And state-wise prevalence is also not known. We don't know in Delhi how many are B and C, in Punjab how many are there. Each state is not doing a very rigorous checkup. So that is why this need was felt that yes, this is an infection, it is there, and you need to concentrate your efforts towards developing a program. So that, like when we felt that there was a need for HIV work, it was driven as a program, National AIDS Control Program. TB was a problem, so you had National Tuberculosis Program. Malaria, you have Malaria Program. You have Vector-Borne Disease Program. So when you make it as a public program, the things are much sorted, even to the smallest of the districts and government hospitals. The facility can go, and the services can go even to the lowest level of healthcare. And that is why the need was felt that you should have a national viral hepatitis control program. ILBS did a lot of effort, and since I am attached to ILBS from the very beginning, 2007 and 8, so we were a part of making these guidelines. We all concentrated our efforts with the government of India, with WHO-CC, and we did consecutive meetings. Here at ILBS, we pushed, the government that really this is a problem and please make a national program. So these are all documentation and recordings of those technical consultation meetings which we did in the year 2014, 15, 16, and 17. And so finally, we could convince the government, and fortunately, I'm there as a technical expert in the National Viral Hepatitis Control Program, as well as in the Delhi State Control Program. So this was launched in July 2018 by then Health Minister Shri Nadda ji. And these are the guidelines which were made, which are documented. 2018, most of them were there. 2 of them, like National Action Plan and for Hepatitis B, came in 2019. They are freely available. You can log on to Government of India or just type National Viral Hepatitis Control Program Guidelines of India, and you will have these full documents where each and everything is given in a very simplistic manner. So they are freely available, or you can ask us, ILBS can provide you these guidelines. Now, interestingly, what are these guidelines like? So they have made a program how hepatitis B and C and A and E, they all will be managed, diagnosed, where the drugs are going to come, how the test kits are going to come, who's going to test, how are they going to refer, what is the chain of reference. So all these things are actually given in detail in these operational and management guidelines. So you can read and then understand that what is in it. Unfortunately, when these were launched in the year 2018 and 19, after that, the COVID pandemic occurred in 2021, and you all know we've been struggling with it. And the Government of India and the NCDC, which is the main sector for management of these guidelines, got very busy in the COVID, and all the virologists across the country. So the implementation in each state was not that fast as we anticipated, but now somehow the work has again started. Few states have done very good work, and we did 15, 16 training of trainer workshops at the Government of India level, and then calling the nodal officers and training them. But unfortunately, that work could not take the shape in that accelerated manner the way we thought that this program is going to go. So this program, National Viral Hepatitis Control Program in India, is different from the other countries in a way that there is many national viral hepatitis program in Thailand, in Egypt, it is there in Australia, but they usually focus on hepatitis C. So our country, first we made it for hepatitis C, and then we pushed and persuaded our health minister that hepatitis B component should also be added. Although the commitment of hepatitis B is much larger, because hepatitis B patients, they need to be given a lifelong treatment. But still, I must appreciate our government's effort that they said that no, include B also, and that is why hepatitis B guidelines came in 2019. Hepatitis A and E are also included into it, although they say that screening we will do, but management will be done under the other program, which is already existing. So the objectives are community awareness needs to be increased. So IEC activity, and so is these webinars and all. So the Government of India, WHO centers, they all are pushing that. Please write projects, do IEC activities, give information. So at ILBS, as Archana had shown, we have been doing through empathy campaign. We have a Project Prakash going on. We have an eco-teaching platform. We also have another eco platform as WHOCC, where we are disseminating the knowledge about viral hepatitis, and through this webinar. We have to focus on early diagnosis and management. So do screening, testing, identify, and immediately put the patient onto the management cascade. Means you identify, you should know where to send the patient, just like you do in HIV. You have voluntary testing centers, patient is screened, tested, and immediately sent to an ART center. This is the same way this program works. You do testing and refer them to a treatment center, and the patient should receive the treatment before his liver goes and becomes cirrhotic and gets complicated. Then you have to link, because A and E is a huge, these are the viruses which you get infected through unsafe water and food, and you can diagnose them, but then their management does not actually require, it requires more of preventive measures like safe water, hygienic practices, safe toilet practices, and all those things. So we are going to link them to the other existing national programs like Swachh Bharat and all those initiatives by the Government of India. And then the idea is that we should have this entire program, and the Government of India is working on it. It should be like a one whole soul viral hepatitis information and management, where the registry is done for all the patients who are infected and what needs to be done. So finally, we are moving on to it. So the awareness activities have started. Certain states have started the diagnosis and management and developing their guidelines. Linkage to the other national programs and developing a web-based registry system is on its way. Now, this is a organogram of how this program is all about. In the center, this program is controlled by National Health Mission, and the Additional Secretary Health or Secretary Health at the central government is the whole soul in charge for at the national level. At the national level, they have already made this National Hepatitis Management Unit. They have made the technical resource groups. And fortunately, I'm part of these technical resource group at the national level. Each state has to make its own state viral hepatitis management unit. And this is a responsibility of State Health Mission. So just like National Health Mission, you have in each state, State Health Mission. So whosoever is in charge of this has to see that this program is made. Each state should have model treatment center depending upon your need. Suppose your population is very high, so you can have 2 or 3 or 4 model treatment centers. You can have one state lab where most of the facilities for typing, genotyping, etc. is available. Now, this program is flexible. Now, the state viral hepatitis will control at the district and sub-district levels, and it will go down to your district and the primary health wellness centers and primary health centers level, where the diagnostics and the drug dispensation will be given. The flexibility is that we have told each state that if you don't have a very good government state available where the testing can be done, you can outsource also to private labs. You can partner with the private labs so that testing is not hampered. And so they are not going to give you budget for buying equipment and establishing lab. Rather, they will just give the budget for purchasing the consumables and reagents to do the testing. So if you have a lab where the facilities are available, please start testing and be a part of it. And then you can have reimbursement of the reagents and consumables because the money is going to come to the states. So this is how the organization of this national program at the national level and at the state level is done. So the national level usually is involved, which is the NCDC is the main focus, although the program is controlled by the Secretary Health, Government of India. Through their office, they will make guidelines, policies. They will do central procurement of reagents for the screening, that is the card test, because it has to be quality assured, and then they will send it to states and states can send to their site. So you can have put an indent for the RDTs and that can be given to you. State level, you liaison with the national, you take a budget and then you make reagents and consumables at your state level labs or your and the drugs also to your various prime district and sub-district sites. So the components, again, this has been touched upon, is that this program focuses on generation of awareness generation. For especially the focus is going to be on hepatitis B immunization, which previous speakers have also highlighted that what is lacking is the birth dose vaccination. And these are the two important components in the preventive aspect we are going to focus. Diagnosis and treatment for hepatitis B, C, A, and E is going to be based on screening by serological test. Now, RDTs have been shown by previous speaker Archana. These are the rapid diagnostic tests, rapid card test, like a sugar card test. You just prick, put a drop of blood, and if it is positive, comes out positive, negative within 15 minutes. So these are the screening of this for hepatitis B and C will be done in this program by RDTs. These RDTs will be procured, or at least the specifications and all are going to be vetted at the national level, and then the states can buy them, and then they can, if you become one of the testing sites or drug disbursement sites, then you can procure these RDTs from your state for B and C, for hepatitis B surface antigen and antibody to C, and start screening all population. So whom are we actually screening in India for viral hepatitis? Actually, it is being done at the blood banks whenever you go to donate blood, or before an organ donation in donors and recipients, or at the ANC centers, but not for all. But under this program, we have recommended strongly that you should screen all. So all, and it should be free testing. So you will make viral hepatitis testing units in your hospital, and where these RDTs are available, and any person can walk in and can have the information about hepatitis B and C test on their own. The confirmation, once a screening test comes out positive, is confirmed by molecular test, that is the RT-PCR, viral load, or PCR test. Now, they will be done at your lab, the state viral lab level, or if you do not have a facility, you can outsource to a lab and can, have a budget for reimbursement to the private lab testing, so that the report of hepatitis B DNA and HCV RNA can be handed over to the patient in in a very shortest possible turnaround time. If it is an uncomplicated case, which I'll come to for B and C, what are uncomplicated cases? Means you have a very simple disease, you just are hepatitis B DNA or C RNA positive, liver is normal, no cirrhosis, then the treatment can be given to them at the primary health sub-district level and the primary health center level only. The drugs will be made available through this program at these levels. So the simple medical officer who is sitting in these centers will have a list of hepatitis B drugs and how to give, and hepatitis C drugs and how to give. For uncomplicated cases, they can give the drugs, and then follow up of the patient can be done by them. In case you feel that the case is complicated in terms of there is cirrhosis of the liver, the it's a co-infection, it's a pregnancy associated BNC, all those which are defined in those guidelines, you can refer to those guidelines, what are complicated and what are uncomplicated. So the complicated cases will be managed only at the model treatment center. Each state can have 1 or 2 model treatment centers where the facility for managing complicated cases in terms of they should have a very good radiology setup, they should have ultrasound or other methods of diagnosing, they should have an endoscopy services available, so they should have a gastroenterology setup in their place, and in case they should be attached to any tertiary hospital for a transplant if the need comes. So these are the requirement for a model treatment center, and complicated cases can be referred to them. And then the process of referral and linkages is very clearly defined in this National Viral Hepatitis Program. Now, this is just to tell you that again, in this program, so there are so many tests and algorithms available for viral hepatitis, but in this program, we focus on the sample, which is blood from its serum and plasma can be separated. We are going to focus mainly on the rapid diagnostic test for B and C. Rapid diagnostic tests are the simple card test, and on which a simple drop of a blood is put and positive negative result is there. In case of the complicated cases or there is some confusion, then at the state level lab, the facility for ELISA or a much sophisticated instruments like a chemiluminescence immunoassays will be made available, and there the testing can be done with these more sensitive and specific assays. Then confirmation is done in case any of these rapid diagnostic tests or ELISAs or this comes positive by a molecular test, which is nothing but a viral load or an RT-PCR setup, which will be again there at the state level lab, not at the district and sub-district level lab, where the viral load testing can be done. And in case if a need is there is a complicated case, then the provision of genotyping by sequencing will be made available. So this is how the hierarchy for the functioning is decided in this, that at the primary health center level, you will be just given RDTs, the rapid diagnostic test, so that you screen all footfall. Anybody who's coming to your district level primary health centers should be screened for hepatitis B and C. Voluntary testing, they can just come and can ask for we should test for hepatitis B and C. At the district level, if you already have ELISA instruments with you or an RT-PCR instruments with you, because of the COVID, I think these things, our facilities can be made available, are there, the instruments are there, then the reagents can be procured by the state and you can do, the districts can do, because they usually have in the district hospital specialized microbiologists who can do ELISA testing or can do viral load testing and report. At the state level lab, you should have entire facility for ELISA or more sophisticated chemiluminescence, and you should be able to do RT-PCRs with a better instrument and more sensitive and specific method. The Center of Excellence, which is going to be the referral lab, should have the facility for sequencing in case of complicated cases who requires drug resistance testing or genotyping. But this is how the division of work has been decided in this National Hepatitis Program. This is again the same cartoon which shows that at the sub-district level, you should be able to screen, and then the treatment can be given because you have medical officers. If you have medical officers, they can be trained to treat the uncomplicated cases. The complicated cases needs to go to a medical college and a tertiary for the management. This has to be made clear. And such training, capacity building, all these can be, so if you become a treatment center or you become a testing center, then you can ask your state that please do handhold us, please do some capacity building exercises. So through the ECO program or through the various other platforms, the National Viral Hepatitis Control Program will take care of all discussions, all hand-holding and all those things so that the capacity is built up. Through this program, as I told you, since we are going to focus on all 5 viruses, which includes A and E also. So we are going to, the meetings are going on, and very soon what will be the component of Swachh Bharat, mother to child program, immunization program, AIDS control program, and injection safety program. All this will liaison with the National Viral Hepatitis Control Program. Now, what are the main challenges we are thinking? So now I have not written the first challenge we faced was the COVID pandemic. So suddenly this program got a backseat, and COVID testing became the main focus, and the government of India also did not push enough for implementation of these programs at the state level. But again, it is going to come up. The largest problem we are facing is that when you do a screening and then you do a confirmation of an active infection by a PCR test is not going to happen, because you really require a lot of microbiology labs who are capable of doing the PCRs and immediately giving the report. Because what happens is that when you just screen a patient for hepatitis B and C, and the person turns out to be positive, if you do not give them the right advice that what is your status, what needs to be done now, where you need to go to get your treatment, they just disappear. They will not take any action. Because why? Because hepatitis B and C is asymptomatic. He is performing well. His liver is not showing any overtly symptoms. And so most of the patients think that, okay, we are okay right now, so we do not require treatment, which is wrong, because gradually the virus is going to, kill your liver in a way that will turn into cirrhotic, and when you will land up into a decompensated cirrhosis, and then you land up into failure. This is how the problem is. So that is why we are focusing that this gap of microbiology testing for PCRs should not be there, and we need more and more microbiology set up in PCRs at the district level, so that the immediate report of a viral load testing is sent to the patient and the treatment and follow-up is started. Another problem we are facing is that of complicated cases, because still uncomplicated, non-complicated cases, we will empower the district and sub-district medical officers for treatment. Now, in case the patient requires some more by a gastroenterology expert, then you should be clear that which hospital, medical college is there with you, where you can send them. So that referral and linkages need to be clearly established. So this is how we are working on it, and we give all the support for any state if they want to ask us that what to be done, how these systems and linkages can be established. So at the National Viral Hepatitis National Unit, Central Unit, we are there to help out each and every state in making these systems very crystal clear so that the patients do not suffer. Now, just talking about what are the guidelines for B and C on which we are going to work for diagnosis and treatment. Hepatitis B virus, you know, it's a DNA virus, so much stable virus. Although there are a lot of genes, surface, core, polymerase, and X, but two important things is these surface antigen, which is there on the surface, by which a person is infected or not infected is clearly identified, because it is an antigen, it's not an antibody, but it tells you about infection. Then if it is just an antigen, because simply an antigen can be there on the surface, or there is an actively replicating virus, which is checked by doing a DNA test. And so these are the two important markers for hepatitis B diagnosis, that is HbA1c screening and confirmation of infection via DNA. Now, this has to be told for everyone that why hepatitis B, although a more prevalent problem, but still one small measure can change the face of this problem, is that 95% of the chronic hepatitis B, as you can see, is when you acquire the infection from mother to child. So in the childhood, as Dr. Ajit has also shown, it is the age which is important. Now, one single step which we are again and again saying is that if we ensure that 100% deliveries are institutional and 100% babies who are born within 12 hours, they receive their birth dose of hepatitis B vaccination, then this problem of hepatitis B is going to be diminished, or it's going to get eliminated. At least we should be very, very hopeful. And so this is the main target. So mostly the infection, because we are only worried about when the virus remains inside and lands up into a chronic liver disease. Although once the virus enters, cannot leave your liver, but will not be able to harm or go into a chronic stage if you are vaccinated at birth. So this is the most important step. When you acquire this infection in your adulthood, less than 5% chance that you will land up into the chronicity. So more problem is that when your liver goes into a chronic stage of cirrhosis and liver failure or HCC, so this can be tackled when you just prevent this transmission by doing 100% at birth immunization of all the babies who are born within 12 hours. Now, once you check for a patient by HbA1c, so I told you HbA1c is going to be the first screening test for hepatitis B. A patient can be HbA1c positive or negative. If negative, nothing needs to be done. Positive means the person is infected. So you need to put the patient to treatment. Now, before putting the patient to treatment, so all HbA1c positive need not to be put on the treatment. You have to see for the liver health. If liver is healthy, means non-cirrhotic, then we do a simple liver function test, normal ALT. Now, if the liver function test, which is SGPT or ALT, is normal, even though the DNA is there, which is less than 2000, no treatment, you just need to follow up. And how do we do a follow-up? Once a patient is HbA1c positive, but the liver is healthy, we keep calling the patient annually to get his liver function test checked and his HBV DNA tested once a year. If any time either the liver function test becomes elevated or DNA becomes more than 20,000, in that case, or there is a cirrhosis of the liver indication you're getting, then you should put the patient on treatment. Now, in case the person is HBsAg positive and the first time itself you found that the patient is cirrhotic by doing a non-invasive test of fibrosis or doing just a calculation by APRI score, you should immediately put the patient on treatment. But in case the patient is non-cirrhotic, normal ALT, once a year follow-up, but abnormal ALT, you need to do a DNA and then put the patient on treatment. So the algorithm for management of uncomplicated cases is very, very simple, because uncomplicated cases, either they are cirrhotic, non-cirrhotic, the DNA is less than 2,000 or more than 20,000. You just need to follow them up that when they require treatment. And once you start a treatment, till now there are no stoppage rule. Hepatitis B treatment is given lifelong. What are the drugs which are available? So they are available free of cost under the national program. The states should indent them from the national hepatitis unit and should keep a stock of what all drugs they have taken and to whom they have given these drugs. So tenofovir, entecavir, they are all, and tenofovir, both the combination, which is DDF and TAF, both are available under the national program, and they will be given at free of cost to the patient, lifelong, whatever. So this is how once a patient comes to a model treatment center or any treatment center is tested for HBsAg, then you get their liver health checkup by doing, you can do non-invasive test, you can do ultrasound, whatever is available, or you can just calculate an APRI score and then decide and get a DNA done and then decide whether the patient requires treatment, make a treatment card and simple drugs as per the treatment guidelines. So you can actually take a download those PDF and what are the drug combinations for how long they are given. A simple medical officer level can give these treatments to the patient and can keep. Now, once you put a patient on treatment, the patient needs to be followed up 6 monthly so that the viral load is tested and the ALT levels are tested so that he is responsive or non-responsive. So that also needs to be done. So this is how the simple uncomplicated cases. In case it is a complicated case, you have to refer them to a higher center and then they will take care of it as per the guidelines. And all investigations, all tests will be done free of cost under this national program. So this is about hepatitis B. Now for hepatitis C, which is a RNA virus, much simpler virus. Now it does not have any antigen, though it has an antigen, but the diagnosis of this infection is made by the antibody it forms to this envelope protein, which we call as anti-HCV. I want to make it very, very clear because most of the queries come. This is an antibody, which means shows protection, because we have learned so much from COVID that antibody is protection. But this virus is unique. The antibody to HCV is marker of infection. Now, whether it is a past infection or ongoing infection, that is checked by doing an HCV RNA. So a person who is antibody to HCV positive, you have to do HCV RNA to confirm that there is an ongoing infection. Only in 20 to 30% cases, you will see that the person has on its own cleared the infection. Means antibody is positive and RNA is negative. But remaining 70% chances are that if you have an antibody to HCV positive, 70% chances are that you are having an ongoing infection, your RNA will come positive. The guidelines say that you just test the patient for an antibody by a rapid card test. And if positive, send the patient's blood for RNA. If RNA is positive, not any viral load, there is no discrimination of 2,000, 20,000 like HPV. Any viral load needs to be treated and refer them to your treatment center. Simple here. Usually HCV RNA, when it is detected, you do not have a lot of uncomplicated, complicated cases. You have mostly uncomplicated cases. So a simple regime in the form of antivirals What are the antivirals which are available? So those who are without cirrhosis, that is uncomplicated, simple B inhibitor. So in the virus, you have NS5B region and 5A. And normally when you are giving bevir drugs, these are targeting the NS5B region of the virus. And when you are giving Asavir's drugs, those which starts with A, you are targeting the 5A. So we target two regions of the virus, NS5B as well as NS5A. So usually this combination is given, and it is given for 12 weeks. You can give velpatasvir in certain compensated cirrhosis, or you can give ribavirin. All these are available free of cost. Only your state needs to procure them from the national and keep them and make these medicines available for the health centers. In HCV, first HCV RNA is done. So I told you in B, once you put the patient on treatment, you need to call every 6 monthly the patient for an HBV DNA and ALT. In HCV, one-time follow-up is needed. You give 12-week treatment. Once the 12-week treatment is given, wait for 12 weeks and then call the patient for doing a SVR test, which is SVR12. And if the viral load is 0, that means stop the treatment, nothing to be given, patient is clear of HCV virus. That is why we use the word eradication of HCV by 2030. You can actually eradicate this virus because this virus never goes and binds to the host genome. So it's not there in your liver, it gets cleared once you give it 12 weeks. So HCV is very, very simple to treat. You can clear this viral infection by giving a simple 12-week all oral treatment, no injections, only oral treatment. There is no need if the patient is on treatment that you keep on doing the HCV RNA. Genotyping is also not recommended, only in cases where it's a complicated case and certain newer drug combinations needs to be started. Then in that case, genotyping is needed or drug resistance. So this is unlike what it was with the interferon era, where we used to type it first and then give a treatment. Here, there is no role. You have to give pan-genotypic treatment to HCV RNA positive. So it's the algorithm very, very simple. When the patient walks in, get an HCV, anti-HCV test done, get an HCV viral load done, all viral load needs to be treated, give a treatment for 28 days package to the patient, follow them up, make sure that the patient adheres to the treatment, call them after completion of 12 weeks of the treatment, after 12 weeks for a SVR test, clears the virus, give a certificate, you're free of HCV. Hepatitis E virus, I'm telling you the algorithm so that you know that which test is needed. It's a very simple virus. Normally you acquire it like it's a normal jaundice, so you will be symptomatic. So you'll always have a jaundice. And peak of jaundice coincides with your one test, which is the IgM test. And that is why a simple blood test by which IgM antibodies are tested, by which you can actually diagnose this infection. Same as hepatitis A. Whenever you have a peak of illness, the jaundice is very, very much there and IgM test is there. And the virus also gets cleared on its own. The disease also gets cleared on its own. So it's not a chronic illness, both A and E. But yes, the diagnosis of acute jaundice can be made for A and E by doing a simple hepatitis E IgM test or hepatitis A IgM test. So this is the algorithm which is proposed, that in case a jaundiced patient walks in, means you are suspecting that he has an acute jaundice. In them, hepatitis A and E test also needs to be done apart from B and C. But in case a patient comes who doesn't have a jaundice, asymptomatic, no, then only B and C. A and E, we usually anticipate that patient should have a frank jaundice. So we will not do A and E test. This is for the labs, the state level lab, which is that what guidelines you have to follow. So it is clear that the National Viral Hepatitis Program is very, very simple. They have made the guidelines very simple. Only thing is that you have to find cases, link them to care, and so that the treatment is offered to all. What is the current status? 710 centers are functional in most of the states, and screening has been offered to about 75 lakh of patients. And certain guidelines are now being formed so that hepatitis B for pregnant women is also clear, and for healthcare worker vaccination should be implemented at each institute level. So we are onto it, and this is the current status. So just to summarize my talk, that yes, it is an ambitious target that by 2030, at least mortality to be reduced by 65% and new infections by 90%. And for this only, the government of India has launched this National Viral Hepatitis Control Program, which has a lot of budget. So please, if you in your state this program is not there, please go knock the door of your state health mission. Tell them that we want this program. We want to make one of our site as district centers, treatment centers, testing centers. If you have equipment with you, the budget is there. Only thing is that it requires that whom to approach and how to go about it, so that the diagnostics in viral hepatitis is increased. Now, this is one program which is going to focus on general population, means anybody, you're not going to discriminate that high risk, low risk. Anybody can walk in and can test for hepatitis B and C. Each state has to make a plan and put the proposal, which again and again I'm saying, to the State Health Mission for coordination, and the National Health Mission will enroll them and will give funds for this program. So I thank you all. If you have any queries, I can answer.
Thank you, Dr. Ekta, for your wonderful session, and we all applaud your initiatives for development of this program. Thank you so much for this. Now I will request Dr. Rahul Gehlot for the administration of pledge.
Thank you, ma'am. Thank you so much. Good afternoon, everyone. May I request everyone to please switch on your camera and raise your right hand so that we can take the oath. And I request you all to repeat after me. I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself
tested and my family vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you so much. Over to you, ma'am.
Thank you, Dr. Gehlot. Now I request all the panelists and speakers to be on board for question answer session. First question is for Dr. Mania, if she's available. We have questions for Dr. Mania's session, related to Dr. Mania's session.
Yes.
The question is, you told there is a increasing incidence and prevalence in India of hepatitis B in respect to the other countries in the world. Can this be attributed to our more focus on the screening and testing as per our programs, or there is any other reason identified for this?
The prevalence of hepatitis is actually reducing. So as I had demonstrated when we compared the previous decade to this one, there is certain evidence that the prevalence has reduced. With regard to the trend for mortality from liver complications, what I had shown was the comparison to the global estimate of the percentage change. Now again, there are severe limitations to that publication because it relies on the certification of death, and also the estimate was rather uncertain. But yes, there is some indication that there may be increasing mortality. So with regard to prevalence reduction, And with regard to increase in mortality, again, more data, more robust data is required. We're not sure what exactly the magnitude of that trend of increases. And that was also depicted by the imprecise confidence interval that was there with that estimate. So, yeah, so I think that answers the question.
Yeah, there's another question.
Because there has been a reduction in prevalence.
There is another question. Is there any gender difference in risk of getting infection?
Well,
are females more prone to get hepatitis B infection?
So again, in terms of the evidence that I had shown from those 3 research groups, the most reliable estimate that is purported is from Schweitzer et al., which have not done a subgroup analysis by gender. So again, there is a lot to be desired in terms of being able to detect a signal with regard to gender being a modifier of the estimate. But certainly more data is required for a certain answer to that question. I think if Dr. Ajit or if Dr. Ekta have another perspective to this, they can provide more evidence that they know of.
I agree with Dr. Mania, because if we talk about different diseases and we talk about different proportion of these diseases with gender, so mostly we see when we talk about more prevalence among men, it's mainly due to they are more going out, more exposed to different risks. So that's why you find that higher proportion among men. But there is no I mean other factor which leads to any gender discrimination or any gender differences between the infection of hepatitis B or hepatitis C or any other hepatitis. So I agree with Mania that we need that kind of data analysis so that we can talk about, is there any significant difference between the proportion among men and women.
Okay, thank you. We have another question for you, Dr. Ajit. As we know that we are given 3 doses for hepatitis as vaccine, but majority of people don't get their antibody test done. So in such cases, there is a large population who is not aware of their vaccination status or protection status after that vaccination. So in such cases, is there any recommendation for the booster doses? Or if yes, what is the interval for that?
There's no recommendation for any booster in general population. So if you have received all 3 doses, be assured that 90 to 98% to 100% of protection has been achieved. So that's true that most of the people, they don't get their anti-HBs titer done. But those like us, like healthcare workers or high-risk groups, if they have any doubt in their mind and they want to be 100% assured that they should not get infection in future because they are involved in some high-risk activities, they can get anti-HBs titer done. Otherwise, for general population, no need to go for anti-HBs titer, no need to go for even for booster also, if all 3 doses are completed.
Okay, sir. There is another question. As we know, the window period is very long for the hepatitis B, and those subjects are potential source of transmitting infection to others. Are there any tests which can be done during the window period which can detect that virus?
We can go for hepatitis B virus DNA testing, even IgM can be done, but during the window period, ideal is to wait for that for that period, because we know that hepatitis B, hepatitis C, they are not those kind of viruses which leads to some immediate damage to liver. They're long chronic infections for many years, decades, and then some damage to liver occurs. So no need to be that worried about that window period testing. So I think a person can wait and get tested later on after 6 months. Dr. Ekta can tell more.
So actually, see, the window period in terms of the incubation, if you are saying, yes, Dr. Ajit has said it very rightly. So we call it window period when we talk about the testing, where you cannot detect anything. So the window period goes more often for screening, like precious blood, organs, donors before giving. And for that, we say that DNA, RNA are better screening methods than these HbA1c or antibody. So there we resort to window period testing. But in a general public, as Dr. Ajit has rightly said, if you are asymptomatic, so it's not going to do more harm if you, so just go and get tested by the simple RDT test for HbA1c and HCV. Although the sensitivity is not 100%, we know you might miss, but at least if you are frankly positive, then you will be picked up because it has 100% specificity and very good test. So then you can be referred. But yes, if you start having some problem, you have an indication that in your family history it was there, especially your mother and your siblings are positive, go and get yourself tested. Then I think you can get yourself screened once in a year, or you have a high risk behavior, you know that you have a high risk behavior, and or your spouse is positive, then you require to be screened by a more sensitive assays. Otherwise, don't have to worry about that we are missing on a window period.
Okay, ma'am. In our health program, what are the provisions for partner notification in case of persons identified to be hepatitis B or C positive? Are there any provisions for post-test counseling as is done in HIV testing?
So in this national, can I answer? Yeah. So yes, through this national program, we are trying to liaison with the AIDS control program as well as the blood banking program. So in case, and the counseling services. So in case you will turn out to be positive for B and C, the post-test counseling will be offered. Your spouse will be tested simultaneously, even your siblings, and your family screening will be advised as well as your kids. And another thing we are going to tell, because through this program, earlier in the blood bank, when you have donated blood, if you were HIV positive, then you were referred to a VCTC center. But here now, very soon, I think it has come also, I have to check, that if your B and C testing are also going to be offered to all the blood banks and all AIDS center. And if you come out to be positive for B and C, we are going to recall those donors for B and C also and offer them the advice and post-test counseling. So donor recall is going to be a major part of this program. We have convinced the blood bank guidelines that they have to start doing it. Our center has been doing it but now it has to come down from this thing. So yes, spouses, partners, even family advice is going to be given if you turn out to be B positive, especially.
And one more question, ma'am. Whenever a program is launched, there is a lot of vaccine hesitancy in people. We have seen this in pulse immunization program. We are seeing in COVID vaccination. So how far this vaccine hesitancy has impacted the hepatitis program?
So this program is very new. 2018, the guidelines have been made, 2019. And again I said that in 2020, we were hit by this COVID thing. So actually with full speed, we have not taken up this program. So the first thing for us was awareness campaign. We knew that this is a program, a new disease. So that is why such exercises like telling ILBS to do these campaigns, Prakash, Eco, Empathy, and the training of the healthcare workers has started. So that we teach you and you go and teach 100 more. So the clarity is there that what is this problem and what is this program. Hepatitis B vaccination, when you're going to make it at the national level, we are going to focus on mother-to-child program. And if you're going to make it mandatory, and it is there as a national program at birth within 12 hours, now only thing we are going to focus is make all deliveries institutional. So hepatitis B vaccination is going to go. So whether it is hesitancy, non-hesitancy, we are going to start from that. Now in healthcare workers, yes, that is why I wrote that there are challenges. We know that immunization program has been saying that adult immunization is there, but how many of us know that these vaccines are available at free of cost? You can avail them through your state health mission, and each institute should start its healthcare worker immunization practices and post-exposure prophylaxis records. This needs to be seen. Right. So it's all there. but right education, right awareness needs to be given to healthcare workers so that they start doing things at their institute and state.
Okay,
Even
thank
ma'am,
you
we
so
can
much, ma'am.
add to Dr. Namta's concern. She was saying that they are getting hepatitis B test done for their sanitation workers every year. So I think instead of that, if you target them to get vaccinated, that will be a more cost-effective approach. If you get all those whom you feel they are exposed to hepatitis B infection, they get them vaccinated, get their anti-HBs titer done, so that now they are immune to hepatitis B infection lifelong. And hepatitis B is in the program since 2007-2008. So vaccine hesitancy is not there if we talk about universal immunization program. Yes, it is there for birth dose specifically. So for birth dose, because the baby is very small, it's intramuscular injection. So there is hesitancy on the part of both family and both even the ANMs, peripheral health workers, who have to give that vaccine in the community.
Thank you so much. Now I have one question for Dr. Samina. Ma'am, you have been conducting a lot of counseling sessions, not exactly on hepatitis B, but otherwise. So what is your experience? How far counseling can impact the behavior change of an individual?
Okay, Dr. Mita, see, you are right that I have not been counseling on diseases. What is basically, I am counseling the students regarding their problem, psychological problems. But if you talk, I've been talking to the student community. So if you talk to the student community, they are also our ambassadors who are going out. And students, because they are on the medical field, they can well connect themselves with it, and they can also respond to it. So I feel that if we include this part in the national program, the advising part or the counseling part, it will definitely go a long way to help it out.
Okay, thank you, ma'am. Dr. Seema Rai, ma'am, and are there any possibilities where some collaboration can be done for research as far as homeopathic perspective is concerned?
So as far as homeopathic perspective is concerned, the homeopathy researches are going on, but till now we are not doing any collaborative study, but we can do that because we are not able to, you can say, all the investigation regarding vaccination also at our own level, but in collaborative study, we can definitely participate. As we know, some of our homeopathic medicine are said to be, as few researchers have done, and they are going to act as hepatoprotective, anti-tumor effect, or immunostimulatory action. It has been, after some, we can say, studies, it has been pointed out. But again, more of the clinical trials have to be conducted. But I think it will be better if we do the collaborative study. We will be more authentic and we can make it more evidence-based.
Okay, thank you all the panelists and speakers for your valuable answers. Now I request Dr. Satya Jain, who is HOD of Community Medicine in Dr. B.R. Sur Homeopathic Medical College, for her concluding remarks and vote of thanks.
Good afternoon, everybody. Now, after this long and very interesting session, this is a very interesting webinar on this subject. And on behalf of staff and students of Dr. B.R. Sur Homeopathic Medical College and Hospital, I thank Professor Dr. S.K. Sareen, who is Senior Professor Hepatology and Director of ILBS, Dr. Umesh Kapil, Dr. Mania Prasad, Dr. Ajit Singh Bhadora, Dr. Rahul, who is not there, and Dr. Archana Ramalingam, and Dr. Ekta Gupta for sharing their knowledge and experience with us, and for taking out their valuable time from their busy schedule. Now, the contents of the lectures are not only interesting, but will certainly going to be very useful in our sensitizing and managing patients and students. I also thank Dr. Seema Rai, Principal of Dr. B.R. Sur Homeopathic Medical College and Hospital, for organizing this joint venture with ILBS. I extend my sincere thanks to all the panelists and participants, without whom this would not have been possible. Now, in the last but not least, I express my gratitude to ILBS and Airport Authority of India for their initiative, the Empathy Campaign, to empower people against hepatitis. Thank you so much.
Thank you, ma'am. Now I hand over to Dr. Archana for further proceedings.
Dr. Namrita.
Thank you. Yeah, thank you so much. And the webinar was truly an enriching experience, to say the least. I thank all the speakers, especially the distinguished panelists as well, who added to our knowledge base. And I, as a student of homeopathy, could relate how knowledge hungry we were and how much it's a precious opportunity for all the students, especially the juniors of the college, Dr. B.R. Sur Medical College. Just a small message that the insights that we got today would be really taking the professionals of homeopathy forward in the domain of understanding hepatitis and the burden that we are dealing with, the challenge of hepatitis B and C especially. So thank you so much for taking out the time and giving us the opportunity. For all the students, there is a link that has been posted in the chat box. This is the post-webinar link. Alternatively, you may also scan the QR code, which is being displayed on your screen right now. Can we have the link displayed on the screen, please? This will take you to the short questionnaire post-webinar, just to gauge the knowledge and assess knowledge-based and enrichment and assessment of what you've learned from the webinar. Kindly get in touch with us for any queries and feel free to ask all the questions that you have regarding hepatitis B and C, and get connected with us at empathycampaign.com. It has a repository of knowledge and information from ILBS, all that you would want to know about hepatitis and what is happening in the field. So get connected with us. Kindly do make sure that you submit these responses, the post and the pre-webinars, and the certificates will be delivered to you in your email ID, emails that you've shared with us during registration. Please download those certificates, and thank you so much for sparing the time and your patient hearing.
Thank you so much.
I am always aware of the weakness and the strengths of my opponents. Let me introduce you to two dangerous opponents which we have to defeat.
1 out of every 25 Indian is infected by hepatitis B or C, which can damage the liver. This infection can remain asymptomatic for many years. Hepatitis B commonly spreads through infected blood from an infected mother to child during childbirth, through unprotected sex, through infected needles.
For a long and healthy life, make sure you get tested for hepatitis B and C.
This infection is not contagious, so a hepatitis B or C patient is not a threat to anyone.
Let's learn more about hepatitis B and C. Spread awareness. Let's get tested, let's get treated, and let's defeat this deadly infection together. Hepatitis harega, India jeetega.
For more information, log on to theempathycampaign.com.